And we will welcome everybody to our, I think, let's call it the first annual MCSQI, VCSQI Virtual Data Managers Workshop. Thanks all for being here with us this afternoon. Hope you all are staying warm. And it'll definitely be warmer in here in the Zoom room than it will be out there. So hope you stick with us the next 3 or 4 hours here. We do have a pretty packed agenda planned. So after some opening remarks here, we have a talk from Dr. Salinger at University of Maryland, St. Joseph. Dr. Salinger is potentially unavailable to join us live, but he has recorded a talk for us to listen to, and then he hopes to join us potentially later on this afternoon for some live Q&A. So we'll kind of see where we can fit him in if he's able to show up. And seems like you guys have already found the chat box as well. So any comments, questions are most welcome. This is an open Zoom room as well, so feel free to take yourselves off of mute to interact, to engage, share your questions, comments with the team, and we'll have some fun this afternoon. So after Dr. Salinger, we have a few other presenters. We have Aaron from Rush, who also presented at AQO. We'll have Amber from Biome. Of course, the wonderful Melinda from STS to do some Q&A, and also Dan Alejo from Johns Hopkins to give examples for how Hopkins is using some really cool analytics and data capture mechanisms over at their center. And with that, I will pass it over to the lovely Judy Smith, who is our VCSQI Quality Committee Chair and just such a lovely person, always so helpful and great, at these meetings, and really anything you want, Judy's there. So I can't speak highly enough of her. And Judy, I'll pass it over to you.
Okay, well, I'm not sure I can add any value, but I guess I want to say thank you all for your commitment and, hopefully you'll get a lot out of today, but just really appreciate. I mean, I think it's amazing the work that you do, and I'm so just proud to know all you all, and I'm impressed with the work that you do and your integrity and the integrity in your work. And I just feel privileged to know you and to be on a group call with all of you. And I hope that we can all learn some things today and go with the flow. So thanks, Sadie.
You're so welcome, Judy. So first up, we will start with our recorded talk from Dr. Salinger. So I am going to share that presentation. You have to let me know if you can hear the audio on here.
I'm Ron Salinger from University of Maryland, St. Joe's. I'm a cardiac surgeon. I'd like to thank the
Really
data
quiet for
managers
me,
for inviting
Sadie.
me to give it. Generally, if you're watching this video, that means I'm still in the operating.
One sec. Okay, we're gonna try this again.
Good afternoon. I'm Ron Salinger from University of Maryland, St. Joe's. I'm a cardiac surgeon. I'd like to thank the data managers for inviting me to give a talk. Unfortunately, if you're watching this video, that means I'm still in the operating room and have so far been unable to make it in person, although I'm still hopeful that I'll make it at the end of the talk for a live question and answer period. My talk is a broad-based talk on mitral valve surgery entitled Mitral Valve Surgery A to Z. This is going to be a case-based presentation. Some of the topics I'd like to touch on are primary mitral regurgitation versus secondary mitral regurgitation, I'd like to outline some of the stronger indications for surgery in patients with mitral regurgitation. We'll talk a little bit about repair versus replacement. I'd like to touch on particularly ischemic mitral regurgitation as a particular type of secondary mitral regurgitation that we deal with often in our patients. And then I'd like to talk a little bit about transcatheter edge-to-edge repair, also known as MitraClip procedure, and transcatheter mitral valve replacement. And hopefully at the end, if I'm able to make it, we'll have a live question and answer period. First case I'd like to present is TH. TH was a 68-year-old man admitted with progressive dyspnea and heart failure. Had a 3 out of 6 systolic murmur and bilateral lower extremity edema. Echocardiogram showed P2 flail with severe mitral regurgitation and ejection fraction of 55%. A couple of things about that echo. An ejection fraction of 55% may sound normal, but in a patient with severe mitral regurgitation, any ejection fraction less than 60% is clearly abnormal. And even if it's 60%, it still may be abnormal. And that's because that ejection fraction is really just measuring the percentage of blood that is ejected when the heart squeezes. And if the mitral valve is incompetent, then it's very easy for the heart to put more blood into the left atrium because it's a low pressure system. So that if you have severe MR, you can artificially inflate your ejection fraction with a weaker squeeze because you could park a lot of blood into the low pressure chamber of the left atrium as opposed to pushing it out of the aortic valve against systemic blood pressure. So this patient we know already has some ventricular dysfunction. P2 flail means that the leaflet is flailing up, and that would be classified as primary mitral regurgitation. TH also underwent a cardiac catheterization, which showed a 60% stenosis in the left anterior descending artery. This is a picture of his transesophageal echo. This is the mitral valve. Here, hopefully you can see my pointer. There's 2 leaflets. The leaflet on the left-hand side of the screen is the anterior leaflet. The other leaflet is called the posterior leaflet, and this is a shorter but wider leaflet, or kind of longer along the annulus. The posterior leaflet has less height, but it takes up 2/3 of the annulus. The anterior leaflet only takes up 1/3 of the annulus, but it takes up about 2/3. It's 2/3 height-wise of the valve, so it's a much taller leaflet. And you could see that on this echo, this anterior leaflet, which looks fairly normal, is much taller than the posterior leaflet. You also see this extra white line above the valve and coming above the mitral annulus, and that is the middle scallop of the posterior leaflet, which is no longer supported by chordae tendineae, which is flailing up backwards into the left atrium and making the valve incompetent. This is another view of the same valve. Again, the anterior leaflet is on the left, the posterior leaflet is on the right, and you see all this tissue up here, hopefully you could see my pointer, all this tissue up here above the level of the anterior leaflet is posterior leaflet that is just flailing up along with a cord that is attached to that leaflet, flailing up above the valve and not providing any seal. If we add color flow, we then see the direction the blood is flowing. And we see during systole that this color jet going backwards is mitral regurgitation. It's eccentric. We've now switched orientation so that anterior is now to the right. So this is an anteriorly directed jet. This is a severe amount of regurgitation. It's eccentric, so it's even more than it looks. And this is why this patient has heart failure. This is the same valve shown in 3 dimensions. Anterior leaflet is at the top, posterior leaflet at the bottom. We divide each leaflet into 3 scallops. So for posterior, we label those scallops 1, 2, and 3. In the posterior leaflet, we label P1, P2, and P3. That middle leaflet, or P2, you can see, as you may be able to appreciate, is bulging up in this view. You can see every time the valve closes, there's something flapping up closer to us, and that's the enlarged P2 scallop. With, you may even be able to appreciate there's ruptured cords flipping up into the atrium when the ventricle squeezes. TH went to the operating room, and as expected, there was a large P2 scallop that was flail. It was no longer supported at all. The P1 and P3 scallops of the posterior leaflet were normal, which is a perfect situation for repair because they give you a reference of how to resuspend that leaflet. The anterior leaflet was normal. We performed a triangular resection of P2 scallop. We got rid of the unsupported tissue, and we placed a 34 millimeter physio-annuloplasty ring. These are some intraoperative pictures that...
Just pausing it for a second, it seems like there might be an issue with the video here. I'm going to start it again. I don't know why. If it was advancing on your screen, it wasn't advancing on mine for some
No,
reason.
it didn't advance on ours either.
Okay.
I think we
supported
can
at
just
all.
start from here.
The P1 and P3 scallops of the posterior leaflet were normal, which is a perfect situation for repair because they give you a reference of how to resuspend that leaflet. The anterior leaflet was normal. We performed a triangular resection of P2 scallop. We got rid of the unsupported tissue, and we placed a 34 millimeter physio-annuloplasty ring. These are some intraoperative pictures that are trying to show the valve, hopefully in a way you can understand. This is the anterior leaflet at the top of the picture, posterior leaflet at the bottom of the picture. You're looking inside the left atrium. This is how the surgeon sees it. Again, anterior leaflet, posterior leaflet. And you can see in this bottom right picture, this area here, hopefully you can see my pointer, but the area that's sticking up, and it almost looks a little bit triangular, that is the large unsupported P2 scallop. That's very abnormal. It's, matter of fact, almost all of what you're looking at in this lower picture, lower right picture, the whole posterior leaflet is basically the P2 scallop. It's obscuring the P1 and P3 scallops because it's so abnormally enlarged. This is a picture during and after repair. You can see in this top left picture, the sutures you see are annuloplasty sutures helping to expose the valve. You see on the posterior leaflet a suture line because that P2 scallop has been largely resected and then sewn back together to get rid of the redundant tissue. And then in the remaining pictures, you see the annuloplasty ring with saline filled in the left ventricle, and the valve is now competent. It's holding water. There's nothing leaking back into the atrium. That's a successful repair. And we prefer repair when you can get a durable repair. Generally, durable repairs are achieved when you have someone with primary mitral regurgitation. So the difference between primary mitral regurgitation and secondary mitral regurgitation, primary regurgitation is a patient like this, where there's abnormal leaflets. Usually some part of the leaflet is flail or prolapsing. You could have isolated posterior leaflet prolapse, isolated anterior leaflet prolapse, or you can have bileaflet prolapse. That's all primary mitral regurgitation. In secondary mitral regurgitation, the leaflets themselves are normal. The valve is essentially normal. Although it may be calcified around the edges, the leaflets are normal. And there's some deformity, something is deforming the valve to cause it to leak. Usually it's left ventricular dilatation or remodeling. And that remodeling can either be from ischemia, including a heart attack, or it can be from a non-ischemic cardiomyopathy that just causes the ventricle to dilate and pulls that valve, it pulls the leaflets apart and down into the ventricle so they don't seal well. In secondary MR, you can repair those valves, but the failure rate is about 50% in the first few years. So just putting a ring on those valves is not considered the best treatment. If patients need surgery with secondary MR, the better treatment is a chordal sparing mitral valve replacement because it's more durable, and that's been studied. This is a picture of the same patient after that repair that you saw. This is the echocardiogram. So you see that the leaflet, there's nothing flailing up anymore. This little white thing you see pointing up is a suture. The leaflets are below the level of the annulus coapting. Here's a picture with color showing that no blood is leaking back into the left atrium when the ventricle squeezes during systole. It's all going out the aortic valve. So there's no MR post-repair. It's a good situation. Heart looks good. This shows the heart looks great. This is another view with color showing that this is the repair down here. The left ventricle's on top, the left atrium's on the bottom. There's no blood leaking back into the left atrium. Another shot of the same thing, no MR. Okay, so we talked about primary versus secondary mitral regurgitation. We could talk a little bit about repair versus replacement. We talked a little bit about it in secondary MR. But for patients like this who have primary mitral regurgitation, we prefer the repair. The repairs are durable for primary mitral regurgitation. They have a failure rate of about 1% per year. So they're not perfect, but they're durable. But that means that in 20 years, 80% of the repairs are still intact. The reason we prefer repair is because it's less traumatic to the heart function, and there's probably better preservation of cardiac function for the long term. There's less foreign material in there. And if you have a younger patient, you don't have to make the choice between putting a bioprosthetic valve, which is going to wear out, versus putting a mechanical valve, which commits them to Coumadin, with all Coumadin has its own bleeding complications for the long term. So repair, you don't have to worry about any of that. And those are the reasons we prefer repair for primary mitral regurgitation. These are the indications for mitral repair surgery, and I put them up just to show that they're extensive. And there's different levels of indications, different strengths. So what you really need to know is what are the class 1 indications for mitral repair surgery for patients with primary mitral regurgitation. Those are leaflets that are flailing or prolapsing. And class 1 indications are a patient who has severe primary mitral regurgitation and has any symptoms at all. Usually you're going to be short of breath. What about asymptomatic patients? So if you have no symptoms, but you have severe primary mitral regurgitation, so you have a prolapsing valve with severe leakage, but no symptoms, there's still a class 1 indication to send that patient to surgery if their EF is less than 60% or their end systolic diameter is greater than 4 centimeters or 40 millimeters. The reason for that is that even though the patient says they have no symptoms, they're already showing left ventricular dysfunction or ventricular remodeling that's going to affect their long-term survival. So they're better off having surgery. There's class 2A indication for surgery. Now 2A means that it's a pretty strong indication for surgery, but the patient should be given a choice. That most of the time they would be better off with surgery, but it's not quite as strong as a class 1 indication. So a 2A indication for mitral valve repair in a patient with primary MR is an asymptomatic patient who has severe primary MR, but they do not have any signs of left ventricular dysfunction. Their left ventricle is not dilated, their EF is greater than 60%. But if the surgeon that's taken the operating room has a greater than 95% chance of a successful repair and not a replacement, and they have a demonstrated mortality risk of less than 1%, then it's still acceptable to offer those patients surgery as a choice. And the reason is, many of those patients will progress to have left ventricular dilatation or LV dysfunction. And if we miss the window and they come back with severe LV dysfunction, then they may never get back to having a normal heart. So they may not get the full benefit of surgery. This is based on a now older but very well-known study done by Maurice Serrano at Mayo Clinic that showed that any degree of primary mitral regurgitation, even if asymptomatic, decreases long-term survival. And the more severe the regurgitation is, the bigger the mortality risk. And this is a graph from that famous article showing the lower survival. So the more severe the mitral regurgitation, the lower their survival at 5 years. And so this lowest line had the most severe mitral regurgitation, and then as it got moderate or mild, it was still below normal, but less dramatic. Another case, a 68-year-old woman with subacute onset of cough, hemoptysis, orthopnea, and bilateral leg swelling over about 9 days. She presented in sinus tachycardia. She had JVD, bilateral rales, also had a systolic cardiac murmur, and mild lower extremity edema. We obtained an echocardiogram that showed a flail P2 segment of the mitral valve with severe mitral regurgitation, hyperdynamic ventricle with an EF of 70% because it was pumping into that low pressure chamber. So this probably happened relatively acutely. Patient also had moderate tricuspid regurgitation. She underwent cardiac catheterization, which showed normal coronaries. These are some clips from her echo. Again, this is the mitral valve with the posterior leaflet this time on the left, the anterior leaflet on the right. You may be able to see it on like every other clip. There's a white line that comes above the leaflets. That's the flailing P2 scallop. And the resultant jet, because it's the posterior leaflet that's flailing up, the jet is going anteriorly up the wall of the atrium, and it's a severe jet. This is the same valve in 3D. You can see this, you may be able to see the posterior leaflets on the bottom, the anterior leaflet on the top. You can see this tissue coming up, prolapsing up into the left atrium with each heartbeat. That is the P2 scallop with some associated torn cords. This is the same echo with a still shot where you can really see this prolapsing P2 segment. It's actually, we call it flail once the cords have totally torn, and you see torn cords here and here on this P2 scallop. This patient was taken to the operating room, and what we found in the operating room was a large flail P2 with ruptured cords. The P1 and P3 scallops, which are on either side, P2's in the middle, were normal. The anterior leaflet was generous, but basically normal, well supported. And the annulus was dilated. So what we did was we put 4 Gore-Tex neocords, which we connected to the papillary muscles in the ventricle. We resuspended that P2 segment of the posterior leaflet at the right level. And then we added a 34 millimeter physio ring, which for this valve was downsizing it just mildly. This shows the post-repair echo. So I don't know if you can appreciate this, but there's a little bit of white thickness here. This is the annuloplasty ring. These are the leaflets below the ring where they should be, below the annulus. They're coapting together. You can see there's color on this clip, and no blood is leaking back up into the atrium. So there's no MR. It's a successful repair. This is another picture of the repair post-op. You could see after we repaired the mitral, we also repaired the tricuspid, and there was no tricuspid recurrence either. And this is another clip post-repair. You can see both leaflets are moving. There's great coaptation of the leaflets below the level of the annulus, which is exactly what you want to see. Another clip just showing that the left ventricular and right ventricular function great after repair. Another clip with color showing no regurgitation. And this is another clip, but you guys get the point. So we talked a little bit about this, but just to recap, mitral repair versus replacement. So primary mitral disease, or some people call it organic mitral regurgitation. Repair is recommended. You will use a replacement if a repair fails, if you try to repair it in the operating room, but your repair doesn't look good and you can't figure out how to make your repair competent, then you use a replacement in that case. A good valve replacement is better than a bad repair. And then you have to decide which prosthetic valve is better. The bioprosthetic valves, so the porcine and bovine valves, don't last as long in the mitral position as they do in the aortic position. So you have to consider mechanical valves at an older age in patients when you're doing mitral surgery. Secondary mitral disease, secondary mitral regurgitation, also referred to sometimes as functional mitral regurgitation. There's two basic types, either ischemic mitral regurgitation or non-ischemic dilated cardiomyopathy. And again, the valves, the leaflets themselves are normal in these valves. It's external forces that are remodeling the heart that cause the deformity of the valve and the valve leaks. Many surgeons will use the analogy to a pair of French doors. The doors may be perfect, but if you took the door frame and bent it out of whack, then the doors won't close correctly. And that's what happens to the mitral valve in secondary mitral disease. There was a famous French surgeon named Alain Carpentier who began mitral valve repairs and popularized it and trained many surgeons around the world. And he had a classification system for valve dysfunction, which is also used. It can be applied to both primary and secondary MR. And this is just so you're aware. Type 1 is functional or secondary MR. The other types, type 2 is prolapsing primary MR. And type 3 can be primary or secondary, although type 3B is almost always from ischemic mitral regurgitation, and it's a restricted closure, meaning the valve won't close all the way. I don't think you need to know that level of detail, but if you're asked to classify it, you may want to know where that came from, so that gives some background. And you can always look up the specific definitions of the different types. So there's a particular type of secondary MR that I'd like to spend a little bit of time on because it comes up a lot and it's a difficult topic. And that's ischemic mitral regurgitation, particularly chronic ischemic mitral regurgitation. So patients who have extensive coronary artery disease. They have left ventricular dysfunction. They remodel their ventricle. That valve leaflets get pulled down into the ventricle. The posterior leaflet gets pulled down disproportionately to the anterior leaflet, so they don't line up well anymore, and not as much leaflet overlaps when they come together, and there's a leak. If that is leaking severely and the patient is going to the operating room for a CABG or an AVR, then it's a class 2A indication to treat the mitral regurgitation, and most surgeons believe that it's even stronger than that. Most surgeons would say if it's severe, you need to treat it, or the patient's not going to do as well long term, maybe even in the short term recovery period, but certainly long term from a quality of life and symptomatic standpoint. So if you have severe chronic ischemic MR and you're going to the operating room anyway, you're going to treat that MR, either with a repair or a replacement. The question is, if you're taking someone to the operating room anyway, usually for a CABG, say you're doing a CABG times 3, and they have moderate ischemic MR, should you do anything about that? Well, this has been studied. If you just take the patient and you do just the bypasses, then there's basically a rule of threes. 30% of those patients, the mitral regurgitation will get better, 30% it will stay the same, and 30% it will progress in the future at some point. So CTSNet did a randomized trial taking patients with moderate ischemic MR that were going to the operating room for a CABG, randomized either to fixing the MR or to just doing the bypass grafts. And the issue is, if you also add mitral surgery to the CABG, then it becomes a longer case, a more involved case with higher morbidity. The results of this trial are listed here. If you skip to the bottom, actually, going from the bottom to the top, they included patients both who had acute MIs and who didn't. And they found in follow-up that patients who had mitral valve repair were less likely to have moderate or severe MR in follow-up, which makes sense. If you don't do anything to the valve, less chance you're going to decrease the mitral regurgitation. But if you look at this top group of findings, these are the outcomes. There was no difference in survival, no difference in major adverse cardiovascular or cerebral events between the mitral valve repair group and the CABG alone group. There was also no difference in left ventricular reverse remodeling, which means the ventricles didn't shrink down more in the patients who had mitral repair. They were the same. There was also no difference in functional status, readmission, or quality of life at 1 year in patients who had just a CABG versus CABG mitral. However, there were more neurologic events in the mitral valve repair group, driven mainly by events that occurred postoperatively. So after this trial came out, most surgeons felt that if you're taking a patient to the operating room for a CABG and they have moderate ischemic mitral regurgitation, they're just going to do the CABG alone because there wasn't a benefit demonstrated to addressing the mitral regurgitation. The consensus opinion is that if you take a patient for CABG and they have severe chronic ischemic MR, you should do something about the mitral regurgitation, particularly for quality of life, but it also may affect post-op recovery and morbidity. The question is, what should you do about the mitral regurgitation? And I alluded to this before. Should you repair it or should you replace the valve? And this was a very well designed trial by CTSNet, a very important trial. They took patients, they randomized them either to mitral valve repair. These were patients with chronic ischemic MR, so secondary MR. They had a CABG plus a mitral repair, or they had CABG plus mitral valve replacement, and surgeons were encouraged to do a chordal sparing mitral valve replacement, so they saved those chords. And those chords are important because they maintain the continuity of the mitral valve annulus with the left ventricle, and this affects left ventricular function post-operatively and in the long term. So in those two groups, repair versus replacement, there was no difference in survival at either in the short term or at 2 years. There was no difference in major adverse cardiovascular or cerebral events. Again, no difference in reverse remodeling, no difference in quality of life. There was, however, a 59% recurrence of moderate or severe MR at 2 years in the repair group. So an almost 60% recurrence of MR, 60% failure of repair. There was only a 4% failure in the replacement group. Interestingly, in the subset of patients who had a repair and did not have recurrent MR, those patients did the best. The problem is we can't tell who those 40% of patients are before we repair them. This has led to some surgeons trying to figure out who they can repair without getting a recurrence, but the majority of surgeons favor replacement when they're treating chronic ischemic MR based on the results of this trial. These are the indications for mitral repair surgery in patients with chronic ischemic MR. And you don't have to read all this, but the important thing is the highest level of recommendation you see on the screen is a class 2A. The first two yellow boxes are class 2A, and then it goes straight to class 2B. There's no class 1 indication for surgery in patients with chronic ischemic mitral regurgitation because we just haven't shown the ability to improve survival in this group of patients. Now, at least with mitral surgery, we have not been able to. Okay, time for another case. WL is an 80-year-old man with a 35-pound weight loss, progressive dyspnea on exertion, paroxysmal nocturnal dyspnea, and fatigue. On physical exam, he has an irregular rhythm, he has a loud cardiac systolic murmur, moderate lower extremity edema, and clear lungs. He underwent an echocardiogram, which showed moderate to severe mitral regurgitation with a structurally normal mitral valve. So you know right now that's secondary mitral regurgitation. You guys all have learned that now. He has moderate to severe tricuspid regurgitation, severe dilatation of all four chambers of his heart. He has an ejection fraction of 35%, and estimated PA pressures of 62 millimeters of mercury, which is severely elevated. His right ventricular function is moderately depressed. He underwent cardiac catheterization, which showed a 70% LED lesion and a lesion in a non-dominant right coronary artery. This is a clip from his echocardiogram. Maybe a little hard to see. You may be able to appreciate the left atrium is large. This is the mitral valve, which does look normal. The left ventricle is not moving very well. Some more clips. This shows a severe amount of mitral regurgitation with a large amount of color flow going backwards from the left ventricle into the left atrium with each heartbeat. This shows a moderate to severe amount of tricuspid regurg on the right side of the heart into a very large right atrium. This is a three-dimensional view of the mitral valve, which shows that the valve itself is normal. You may be able to appreciate here that what I was talking about when I said the anterior leaflet is much taller than the posterior leaflet, and it's probably hard to appreciate that the posterior leaflet takes up much more of the annulus, much longer going around the annulus. After a discussion about the risks and benefits, this patient was taken to the operating room mainly to improve his quality of life, which was extremely poor, and he didn't feel like he could go on living in the condition he was in. We found a structurally normal mitral valve with a mildly dilated annulus and moderately tethered leaflets. There was severe tricuspid regurgitation in the operating room with a dilated annulus. He had LAD disease. He had atrial fibrillation as well. So we put in an undersized mitral ring to shrink down that mitral annulus and increase coaptation of those leaflets. We put a 28 millimeter physio ring. We put in a restrictive tricuspid ring, a 28 millimeter MC3 ring. We did a left-sided cryomaze. We ligated his left atrial appendage, and we did a bypass of his LAD with his internal mammary artery. This is a clip of his echo after repair. You see there's no MR on the post-repair echocardiogram. These are the mitral leaflets. You may be able to appreciate there's a ring in here, but most importantly, you see there's no color flow going back into left atrium when the heart beats. This is another shot without color showing that the leaflets are coapting well below the level of the annulus, which is what you want to see. This is showing his function. His left ventricle is moving better than pre-op. His right ventricle is not moving very well, and that will often happen after heart surgery on a right ventricle that's already dysfunctional. Another shot showing that there's no mitral regurgitation. And this is a shot of his tricuspid valve showing that there's little, probably trace to mild tricuspid regurgitation after repair. Okay, so now I want to talk about more recent development of transcatheter mitral technology. And in fact, for the mitral, the transcatheter technology is not all that recent. The first transcatheter therapy for the mitral valve was transcatheter edge-to-edge repair, which is better known as the MitraClip by Abbott. Now there's several different options, but MitraClip is still the most commonly used. This was actually introduced to the market in 2013, although it's gained more use as more studies have been done and more benefit has been shown. The MitraClip is FDA approved for both primary mitral regurgitation in high-risk patients and secondary mitral regurgitation. And I wanted to go over a little bit of the evidence that supports those approvals. So first, when we talk about the MitraClip, just so you get a sense of what it looks like, it comes mounted. This is the handle, this is the working arm, and that's the actual clip, that white thing. The arm itself is a catheter. It goes inside the heart. It goes through the intraatrial septum and then down through the mitral valve while the heart's beating, clasps the leaflets under TE guidance right where the leak is, and you then can deploy the clip if you're happy with how it clasps the leaflets. And oftentimes you'll put two clips right next to each other to really try to decrease the leakage. And this is not like a surgical repair. We're not aiming to get the regurgitation down to zero. If we take severe to moderate, that's decent. If we could take severe MR to mild MR, then that's a home run on a mitral clip. And the whole time you want to make sure you don't clip so much leaflet that you create mitral stenosis by making the orifice too small. So that's something we try to avoid. The initial trials on MitraClip were the Everest trials, and there was an Everest trial and an ongoing registry, Everest 1, Everest 2, and then Everest 2 high risk. The Everest 1 trial was patients with primary or secondary MR. They had to have 3 to 4 plus MR, which is basically moderate to severe MR. And it was basically done to demonstrate safety and feasibility, which it did. There was 90% successful deployment of the clip. 75% of patients had 2 plus or less mitral regurgitation at the end of the procedure and experienced clinical improvement. 30% of those patients, interestingly, progressed to surgery at 3 years. There was no patients that ended up with mitral stenosis that was clinically significant. This led to the Everest 2 trial, which was mitral valve repair surgery versus MitraClip. And it again involved patients with primary and secondary MR, which is both, sometimes we call primary MR degenerative MR and secondary MR functional MR. So all those patients were included. About 280 patients with 4-year follow-up. And it was an intention to treat analysis, which means if you were in the MitraClip arm, you got a clip, and then 6 months later had surgery, you were analyzed as if you were a clip patient, not a surgery patient. So sometimes people complain about that and say that those patients really are surgery patients, but this was intent to treat. So the Everest 2 trial results between surgery versus mitral clip showed that there was similar mortality in the two arms over 4 years. And keep in mind that 4 years is not a very long timeline to measure death. So, we usually like to see our patients survive 10 to 20 years after we do heart surgery. But there was a strong trend towards less mitral regurgitation in the surgical arm. Also, 1/4 of the mitral clip patients who were initially in the mitral clip arm progressed to surgery over the 4 years. And there was a similar reduction in New York Heart Association class between the groups. But again, that's where the intent to treat analysis comes into play, because 1/4 of the patients were having surgery. So it was the patients who were having worse heart failure who then went to surgery and then felt better. And then that was counted as a mitral clip success. Still, it showed the mitral clip was successful, it was safe, and led to improvement in more than half the patients. What we learned from the registry was that most clip failures occur in the first year, and that surgery was far more effective in patients with degenerative disease. So if patients have primary MR, surgery for those patients is so effective that it favored surgery in that subset of patients, versus secondary MR, where I showed you that trial where at 2 years, 50 to 60% of patients, even in surgical arms, had a recurrence of MR and a failure of their repair. So people started thinking, this is really where people started thinking about things differently, whether you should get a clip or surgery based partially on whether you had primary MR or secondary MR, because the surgical results with prolapsing valves or primary MR are so good. This led to something called the high risk registry, which was the Everest 2 high risk registry, which enrolled 78 patients that were of extremely high risk. Mortality was on average, the mortality was 8% on average in the study in reality, but the predicted mortality with surgery was 18%. So these are basically patients who were turned down for surgery. They compared these patients to patients treated medically, and there was an improved survival. So based on the results of this high-risk registry, people started sending people for mitral clips if they were too high risk for surgery, in favor of just treating them with medical therapy. Also based on these results, the FDA approved the mitral clip for degenerative MR, which is primary MR. So even though the surgical results are very good in patients with primary MR, the clip actually does better in patients with primary MR too. And it makes sense because, again, secondary MR, there's some other problem. It's like either there's chronic ischemia or there's a non-ischemic cardiomyopathy, and just clipping the leaflets together isn't going to solve that. But if you just have a prolapsing leaflet and the patient's too high risk for surgery and you clip that, then you're going to get better results because the heart isn't necessarily the problem, the valve's the problem, and you fixed it. So patients with degenerative MR and who are very high risk for surgery were being sent for a mitral clip with its initial approval. This has now changed based on the COAP trial. So now the clip is FDA approved for both primary MR high-risk patients and patients with secondary MR. The COAP trial looked at patients with secondary MR who were treated with optimal medical therapy but still had significant symptoms of heart failure and who are high risk for surgery. And it compared medical therapy to medical therapy plus a clip. There was no surgical arm. Basically, the COAP results, which we now have 5-year results, show that there's less heart failure admissions and even a lower mortality through 5 years with a mitral clip versus medical therapy alone. So if you have secondary MR and you have continued heart failure despite medical therapy, you're very likely going to get a mitral clip unless you have some other indication to have open heart surgery. And part of that is because the results with surgery just aren't good enough to justify taking those patients to the operating room just for their secondary MR, except in some cases where the patient is very young and it's a fairly low risk operation, and you can give them, you will still get a better result, particularly if you do a chordal sparing mitral valve replacement. You'll still get a better result with surgery as far as the MR goes than you will with a clip, because with the clip you're going to always have some residual mitral regurgitation. The important thing to think about, though, if you're thinking about operating on someone with secondary mitral regurgitation, is that in this trial, now these were older patients, but in this trial at 5 years, the better mortality was still 57%. So 57%, over half of people died within 5 years. So the life expectancy is not necessarily normal for this group of patients. Secondary MR patients, or patients with severe secondary MR, do not have a long life expectancy. And for that reason, you don't necessarily, if you could do a less invasive procedure, you would lean towards that. And the final thing that I just want to put on the screen is transcatheter, mitral clip and transcatheter edge repair are percutaneous mitral valve repairs, but there's also now transcatheter mitral valve replacement. There's several options, and there's multiple valves that are in trials right now for FDA approval. The Edwards S3 aortic valve has been implanted many times off-label in the mitral position, but there are other valves that are specifically designed for the mitral, and none of them have been shown to be clearly superior, but this technology is going to become a viable option in the near future. Thank you for inviting me. I hope that this answered some of your questions. I hope this information was useful. And I also hope that I am actually there live right now to answer some questions. Thank you. If I'm not there, I'm willing to take questions over email, or better, go to a future meeting and just have a question and answer period. Thank you. Bye.
All right. Well, greatest thanks to Dr. Salinger for his recorded presentation. I don't see him currently in the meeting, but again, he said he might be available later on. So
So
we'll see if he can make
Eddie,
it. Go ahead, Judy.
Eddie, we do have Callie is explaining something to me in the chat. So I'm interested in why primary MR happens. I get secondary. To me, the French door, Callie, was secondary. The door couldn't shut because the frame was all broken. That's secondary. But just this degenerative disease, I always think like rheumatic fever and all that. I don't even know if that's what causes it, but that's interesting to me. But I feel like the French door was definitely the structural damage from secondary. It just seems weird. But can I share my screen, Eddie? And Callie, keep talking to me so I can learn.
Absolutely. Please go ahead, Judy.
Let's see. I'm going to share too, I hope. So we're totally open for discussion, but one of the things I thought in the time we had, because it was so apropos, because he talked about both the interventional, the minimally invasive mitral valve approaches as well as the surgical approaches. And this is something Dr. Habib has done a great presentation on this on the STS national cause, but there is actually a specific mitral regurg, primary mitral regurg paper and the risk model. And I'm sure most people know about this, but I thought we'd go over it a little bit in the time we had since he's not here. But this is the link to the paper if you're interested in it. Let's see here. It's here. And I guess maybe I can try to put that in the chat box. But this was actually made with the heart team approach to kind of show, I think, I'm not sure, but I think it kind of shows that mitral valve surgery is not that higher risk, I think, compared to but it kind, I think, helping make that decision. And this is, if I can get rid of my bar here, this is actually on the risk, STS risk calculators. And it's under here and it says mitral regurgitation risk calculator. And it's incredibly interesting to me, and it threw me off like the first time I did it. But if we take, I think probably one of his patients, what he had, that 80-year-old, and we'll just say he was normal, you know, we'll make him very, very normal. He'll make him male, we'll make him not Hispanic. And he'll be a previous smoker, not a, I don't know, he's 80. We can give him some oral. He's not taking any meds, hypertension. And can you see my screen that I'm sharing the risk calculator with primary mitral regurg? Ready?
Yeah, everything looks good, Judy.
All right, thank you. We won't give him any of this. We don't give any meds. So if he has MR, let's give him, that was interesting. I thought that ejection fraction with regurg was interesting. I guess we'll give him, you know, I actually wrote about this because it's like there's no option to say like class 2. And the reason there's no option to say class 2 is because it doesn't affect the model. So I guess saying either leaving it blank or saying no failure is the same thing. We'll say remote heart failure for him. He's elective. This is where it gets interesting to me because we'll say he had no AFib and no TR. And he'll have the prolapse without the flail. When you calculate this, please correct the errors. What are my errors? I don't see anything else red. So for this, because right, we know that mitral valve repair will be favored over it. It's 1.44. And so he has no or mild tricuspid insufficiency. And like to go ahead and fix that is actually low. I mean, it's not a lot, right? But if you, where is the question about what you're going to do here? I guess you don't. So then if we go give him severe, so if someone has severe tricuspid insufficiency and you don't fix it, their risk of mortality with just the mitral valve is actually higher. And and then if you give him AFib and you don't do the AFib surgery, your risk of mortality and major morbidity and mortality is higher. And it makes sense, right? Because if you have it and you don't do anything about it, I did read the paper well enough. Maybe somebody has like, I don't know how far out, like how far out is this mortality? Is this a 30-day mortality? Is this and then it goes intention to treat and then as treated. So if you got the mitral valve repair. Oh, and the other thing I thought was interesting, remember he said like if you could do the repair and you had a certain amount of chance, like I think it was less than 4% chance of getting a mitral valve replacement, that'll actually calculate it for you. So I don't think we use this a lot here, but I do think it's interesting that this is out there and STS did it. And I did ask Melinda, she did have to hop off the call and we can clarify it, but when there's a discussion about did you discuss the risk calculator with your patient, they really are still talking about this one for mitral valve repair replacement. This is the one, you know, kind of the traditional one. This is the one she said. She said as more risk models come up, like with the AVR, MVR, and those kind of things, that they'll actually put that in the training manual about if that discussion changes to a different model. But currently, this is the model that they're asking. Like you don't have to go calculate this other one. So what questions would you have for, yeah, there's a great STS webinar with Dr. Habib on it. Right, so Callie, come on, Callie, you got to teach us here. Oh, the Carpentier classification, that's really good. Callie, do you want to,
So after listening to his presentation, that on primary MR, you can have various, stages of functional leaflets versus they don't come together. And that's what I was trying to say is that French door reference is where there's some sort of structural damage to the heart. So, prior ischemia causing the annulus to be, not able to line up
oh,
those leaflets. So primary MR, usually there's an issue with the leaflets kind of coming together versus secondary, you've got ischemia to the whole ventricle itself. So it can be just kind of dilated or, causing that secondary function not to, work properly. That's what I was trying to send to you.
so in the secondary one, so in this picture right here, I think, am I still sharing my screen? Hello?
Yes.
Okay, so you can see your picture. This secondary MR, which is like the leaflets are fine, the ventricle is what's just pulling it all to six, out of whack, right?
Yes.
Will this always be a 3B?
I don't know the answer to that question. When it
Yeah,
comes
I
to
know.
the actual coding, it's hard if they don't have it, specifically listed what is happening with the leaflets and then the coding itself within the echo report. It's really hard to code and classify the mitral disease. So oftentimes I find in my echo reports specifically that it's just not captured or not documented.
So, Kelly, one of the things oh yeah, that's a good idea. That's what we put a lot to. Um, you know how we talked about in secondary MR, it says the leaflets look fine, right? And they close fine, right? Everything is fine. It made me wonder, can it be normal? Is there still abnormal leaflet function in secondary MR? That's why it's not closing. That's why they've got the regurg. I just got it. I had a light bulb. I got you. Then, Callie, just not for like totally like it has to be documented in the record, like Melinda tells us, like we don't have to make these decisions. But do you think of just generally like the 3A, like we don't touch on mitral stenosis and you don't see it a lot, but is that more what that 3A is, do you think? Or is that only regurg? This only classifies regurg. There's no stenosis Carpentier classification. I had another light bulb. So like mitral stenosis leaflets don't even get classified.
Yeah, that would just be, you'd capture that under your stenosis
Yeah.
specifically. But when we're looking specifically at the regurg, but I think you can still have some regurgitation if you've got, calcification that's kind of blocking the leaflet from closing properly. So there's still a
Mhm.
degree where it could be slightly overlapping, where you might have a valve that has some stenosis, but it also has regurgitation at the same time. But that would have to be clearly laid out within the echo report too.
Other stupid question about that, like if you've got mitral stenosis, and this is just in general, I'll probably have to ask him, but would it seems like you would have to replace those valves. It seems like they don't, I mean, there's no, I guess you could clip some of the things that were stuck together or something, but you don't see it a lot. It's interesting to me what makes all this stuff happen to people.
Well, he kind of
Here is
had
a,
that one example that was where the leaflet itself had that redundancy. So if it's not, super calcified, I feel like sometimes I've seen them where they can take out that redundancy or the calcification, bring it back together, and then put a ring in. And it's sometimes repairable. But when you get
mhm,
into the really calcified
mhm,
valves, I usually see those getting replaced.
mhm.
How about you?
Don't see, I mean, I just, I was trying to think the last mitral stenosis, um, but I remember like, I don't know, I was actually in the unit, like, and they were dropping off the patient and I'm like, did you try to repair it? I mean, I was taking care of the patient. So, and they're, and like the surgeon looked at me like I had six heads. Like she's thinking like, why would I ever even try to repair this valve? So it always made me wonder like, oh, okay, maybe that's a really stupid question to ask. And I don't see it that much, to be honest. I don't see it very often. Um,
Erica has a good comment in the chat box too. And it does make sense, when you're putting extra clips or something on it, if you were trying to do a transcatheter repair, then you're going to make that stenosis worse.
yeah, well, I would never clip a, yeah, no, I definitely wouldn't do anything but replacing versus like, yeah, I don't even know what the other options are for that. This is the sheet. Hopefully, I'm still sharing of what we have to. And this mitral cleft repair, I feel like they say cleft repair, but they don't call it a scallop closure. Anybody have any comments on that? Because I do see that sometimes. Look at that. Hopefully, he'll be able to join us later. Let's see here. See, I always wonder about this when I read it. Like, why is it different from edge to edge versus this? Could you just if you just sewed it together? But if I ever see the word cleft, I always pick that one. Any other, let's see, gosh, if I can ever find it. I think I got one. I do think Melinda on one of the calls said, like, if you see annular dilatation or whatever, like you can use, you can kind of code Cali based just kind of on the words that they use.
Yeah, the only time I find that it gets hard is when you've got kind of overlapping categories. You've got some of
Mhm,
these that could fall within different levels, or within
mhm,
multiple levels. But then if they don't speak to the actual leaflet function, during systole and diastole, then you really don't know what the leaflets are doing and what you can code. So that's where it
mhm,
gets a little dicey with some of the echo reports that I've seen.
mhm. Do your surgeons ever like write it down?
Mine don't typically. Sometimes I can, ascertain what's going on from the op note. So I
Mhm.
can pull info from that. Every once in a while, I'll get a really good echo read that spells it out. But like I said, for the most part, what I end up seeing is that it's just not
I
documented.
don't know. Yeah. Well, I guess that's safer. Does anybody have surgeons that will fill out that worksheet? Watching chat here, like I should be. Sorry to be scrolling in front of you so bad. I guess it's I mean, I even asked one of our surgeons that does a lot of them to just go ahead and code it because to be like a mitral center of excellence, like it's all primary. You can't include your secondary mitral valve repairs in that. So it ends up getting really important and trying to tease out. So I'm like, please write it down. He did for a little bit, but then
Hey, Judy, we've got a member with their hand up, Erica.
Excuse me. So what we did, and it was a huge undertaking, we actually developed a complete smart phrase op note that our providers have bought into and are using because it's making it easier for them. It's a huge undertaking, but what we had originally started with is a very dot phrases for these different, we use Epic, excuse me, dot phrases for these different things that we just could not figure out answers to. And so if they did a mitral valve procedure, there was a .mv procedure dot phrase that they would put into their operative note for us that would answer these specific questions so that we didn't, and they would be in drop downs. We didn't have to sit and go, oh my gosh, what class was this? Where's the regurg? What was this? And so it at least put us in the right direction. Again, it's a huge undertaking, but it has changed our abstraction world immensely.
You know what I love about that too, Erica, is that it puts the worksheets become a question of, do you get them scanned in? Because they would physically have to be scanned in under the media tab. You've actually got all that information in your op notes, or if you're audited, or you know where to look for it, or what if they don't get scanned in, or they don't get scanned in until after the patient goes home and it gets all down to medical records. I mean, to me, that's like such a win-win. Could, off the top of your head, in your mitral valve dot phrase, could you tell us just a couple of things that you added in? Did you add in Carpentier class?
Yes, so that's one of the things that's listed there. So we ask specifically, I was able to essentially run down this list more or less and put it in there. So we would ask what surgery was performed. Was it an annuloplasty, a leaflet resection? If it was, and then this would open up a secondary category. If it was a leaflet resection, what type of resection did you do? And open up through there. We do all of those questions of, did you preserve cords? And if you did, was it anterior or posterior? We ask very clearly, was a mitral repair attempted first? And then, like I said, we do the Carpentier, or however you pronounce that, class, and we give them a little med school reminder next to like the different classes in parentheses of like the very basic, like this is a flail, this is normal leaflets, so that we're all on the same page. And like I said, we got very lucky because our surgeons really, had a lot of buy-in into it and developed it with us as we went through it, because they didn't want to fill out worksheets, right? They were like, this is too non-technological for where we are at. And then our next goal is, because these are now discrete fields, is hopefully once we start doing some more automation and extracts, hopefully being able to use those as discrete fields and pulling them to help with our abstraction and our accuracy, as well as for research purposes. So it's still a work in progress, but it seems cumbersome when you first do it, but they're just opening these fields if they did the procedure. And so, like I said, we now have it as a whole thing. So like we even get into, what did you cannulate? What did you, antegrade or retrograde cardioplegia? We do the whole surgery through basically in this format, and it's written into paragraph form for them that they can edit as they go.
In the long run, I bet it saves them time, because if you've got all the cannulation sites, because even ours, like we don't have that smart phrase, but they all have a smart phrase, because you can tell, because you read the same words in every single, and then they just go fill in, okay, this you're going to have the SVC is going to be cannulated too, right? To drain the heart.
Yes.
Like they have to go back in and change some of the things, but I commend you on that. And I bet it was a ton of work, and your Epic team
it was.
didn't love you for a long time. So you must have that from more than mitral valve then. You must
Correct.
have it
we do basically every single procedure, and it starts as a very, you start at the top and you select, did you do an isolated cab? Did you do a cab valve? Did you do cab valve aorta or valve aorta? And it opens up different fields. So it's not an intimidating looking note from the get-go, at least. And then, like I said, there's probably, I think we calculated there's like 100, if they were to use the entire note, there's like 140 different individual fields that they have options for. Granted, they don't use it for all of that, but it did decrease, significantly decreased our physician queries of what the heck were you documenting here and how do we abstract it? So it's been a win for everybody. We are now trying to figure out how to pack it. I worked with one of my other managers and we actually made the smart phrase ourselves because IT did not have the bandwidth to help us yet because of all the continuous changes to it. So our next step is to get it into an official like system-wide IT built Epic smart phrase. But we've also seen just one last thing. Prior to me taking this role, they had used a flow sheet within Epic to document things like the real basic thing, not basic, but the things like this of, what type of resection was done, what was the Carpentier class, those types of things. And I don't know for sure who filled out that flow sheet because I know our surgeons aren't working in flow sheets. But it got filled out and that's where they got some of their information from.
Cody, I want to be sure not to step on Erin. Has she been able to hop on?
Oh yeah, I'm here.
Erin, welcome. Well, we don't want to take away your time, but Erica, I commend you on that work. It's amazing work. I have one last question. If, say, STS updated or you wanted to add something for research with a smart phrase, you can just go in because you wrote it. You can control it in Epic. You could go add something.
Correct. And that was part of why we chose to control it the way we did. It wouldn't take 6 months to make an update. I love our IS team, but it wouldn't take 6 months to make an update. We could just go in and make it. And there's a couple of us that are owners of it, so that we can adjust as needed.
Well, Erica, you know what the next question is because we all want, and Callie has it in the chat box, but is this something like, I don't know how proprietary it is, but is this something you'd be willing to share? And you don't have to say yes or no now, but just know that's certainly going to be
yeah, I'm working with my surgeon team and my IS team and the leadership team to kind of figure out, is there a way for us to share it? How would we share it? We could probably at least share the formatting of it, and walking through it so that people could adapt it to their needs. So more to come on that. And I'm
Awesome.
I'm in Minnesota, so I'm nowhere near any of y'all. Callie, if you can I just need your email address and then I can start with this.
Callie's close to you. Callie, you're in Idaho?
I'm in Washington State, actually.
Washington State. Yeah, there you go.
Close
Thanks
enough.
for joining us.
It's over there.
All right.
Thanks.
Yeah, no, thank you. It's wild. We are so excited to have Erin on the call with us today. And Eddie, do you want to give a little introduction? Or Erin, we can let you introduce yourself and share your screen and do your own slides.
Sure, absolutely. Thank you guys so much for having me. I'm excited. I haven't talked to or done anything like this with a cardiac group in a while, so I'm pretty pumped. A little about me, I can absolutely, oh, sorry, I kind of messed up my own screen. Yeah, if you want to share screen, I can get started. Part of my talk is I have kind of a little bit about me in it for the first slide, so whenever you guys are ready.
We're ready, Erin. You tell us about you.
Oh, I mean, I can share this, or I can press share. Is
Just
that
share.
correct?
Yeah, you
Okay,
can share, you can start.
perfect.
Thank you.
Okay, thank you so much. Let me know when
Thank
you guys
you.
can see.
So I see it not as a slideshow, but I see your slides and I can read them.
Yeah. Okay, perfect.
There
All
you go.
right,
It's a slideshow now. It looks good.
perfect. Thank you. Okay, so hello everyone on this call on this. Well, I'm in Chicago, so it's -2 degrees here. You guys in Virginia who are actually physically there having a much warmer time than us over here. So my name is Erin McCabe. I am the clinical data manager and quality analyst at Rush University Medical Center in Chicago. Just a little background about me. I have been a nurse at Rush for the last 20 years. I'm now starting on my 21st year at Rush. My whole career has been there. And I worked as a bedside nurse in the neonatal ICU and the pediatric ICU for the first 14 years. Then I ran our hospital's pediatric and adult ECMO programs for several years after that, before becoming a data manager. Since then, I have been overseeing our thoracic database, our adult cardiac database, for a short period of time, our congenital database, and our Intermax database. So I personally abstract for both thoracic and Intermax. I also serve on the national core group as a member for the general thoracic database for the last 2 years. So in this capacity, I've learned a ton through both experience and observation. And I'm here to share my insights on how I believe data managers and their surgeon leaders or clinical teams they work with can work together to optimize their collaborative relationships and hopefully feel less pressure in the roles. Most of my talk really focuses on what we can personally do. As we know as data managers, it's very hard sometimes to change personalities, change habits, and sometimes elicit change at the administrative level. So our focus is going to be mostly on us as data managers. If you know me personally, you know I absolutely love movies. And I thought Barbie, the Barbie movie, actually really paralleled this talk well. So for the women and the men on the call, most of the women I know this movie was very popular with, some of the guys too. So hopefully you've all seen it and you'll giggle and understand some of the references I've made to make this talk a little bit more fun. And so I thought the Barbie movie actually really paralleled the talk I'm about to give about the division of responsibility very well. You see, I didn't see the Barbie movie as just a feminine manifesto. I actually saw it as the story of two groups, the Barbies and the Kens, who were both facing different problems and experiencing different pressures while trying to figure out how to coexist and work together. So hopefully we'll have some fun with this talk. We did at General Thoracic. And so how did I get into the data manager role? Well, after years in a critical care setting and running our ECMO program, I was offered the opportunity to take a role as our cardiac and thoracic data manager. I knew little about it and what the role actually entailed, but I did have experience managing our ECMO registry and our ECMO data, or also registry data. I've worked with surgeons my whole career, mostly general pediatric and cardiac surgeons, both pediatric and adult. Most of the times in very tense and often life-threatening situations requiring clear and strong communication. When offered the role, I thought, well, this is going to be a great chance to do something new. It's also going to be a job that's going to provide me less pressure. It's going to be less stressful and overall compared to what I've previously been doing. So I decided to take the leap into a new world in nursing and clinical and non-clinical care, and I became a data manager. And boy, I thought it sure will be nice to not have to argue with surgeons anymore. And I was wrong. This was basically a picture of a GIF or a video of me in the first 6 months. I didn't know what I just did. I knew absolutely nothing. I felt like I was drowning. I was drinking from the hose, but the hose was in fact a fire hydrant. the vendor software, the reports, the submission deadlines, the data cleanup. There are so many logins and passwords. Why are there so many damn logins and passwords? Oh, and we changed data versions too, and the definition. And we change data elements. And sometimes we add those back in. And sometimes we just redefine the definition of the data element that we just added back in. Oh, and we get audited. And I'm still arguing with surgeons, mostly my cardiac surgeons, and I misjudged some of the things and the pressures associated with this role. So data managers, this is my Barbie monologue to you. It is literally impossible sometimes to be a data manager. We are all so talented and so smart, and it kills me that sometimes we don't think we're good enough or that our surgeons' complications are somehow our responsibility or fault. Like, you have to always be extraordinary, but somehow you're always doing it wrong. You have to be timely, but not too timely, because some administrator might not think you have a big enough workload. You have to take PTO, but you feel guilty taking PTO because you might fall behind in your caseload, and someone somewhere is inevitably going to ask you to pull some complicated report, either right when you're about to go on vacation or take that PTO, or the minute you get back and you're already behind. You have to be a boss, but you can't be mean. You have to lead, but you can't squash other people's egos. For those of us who are moms or parents, you're supposed to love being a mother, but don't talk about your kids all the damn time if you're remote or have remote days in your role, because someone somewhere might think you're slacking or taking advantage in some way. You have to know every single definition of all given time, be looking for other updates, FAQs, and clarifications simultaneously. You have to answer for surgeons, consultants, radiologists, anesthesiologists, cardiologists, bad documentation, which is insane. But if you point that out, you're accused of complaining or being difficult. You're supposed to know all the logins, vendor software, website, database, registry, REDCap survey, application at work, but not so well that you're going to have to update it in 30 days. Anyway, and they're adding a new 13-step multi-factor authentication. So you will finally get into all of your websites, software, and applications necessary to complete your job in about 1.5 hours. But always stand out and always be efficient. And never forget that the systems, the star rating, the public reporting, the risk model, the vendor software, the risk variables, and the data versions are always changing. So find a way to acknowledge that, but also be efficient. And be prepared for an audit at any time, so you can argue with health information management about the patient charts you need and stress until the results come back, wondering how inept you'll feel while every single other project and abstraction you have to do gets put on hold to organize and bookmark everything. You have to never forget a risk variable, never miss a beta blocker, never miss a case. Never be selfish, never get sick, never fail, never so stressed, never ask for money for a conference, and never miss a deadline. Sometimes it all just feels too hard. Sometimes it's just too contradictory and no one gives you a medal or says thank you. And it turns out, in fact, that not only are you doing everything wrong, but everything is also your fault. I am just so tired of watching my fellow data managers tie themselves into knots so that our surgeons, our hospital administrators, and sometimes even ourselves will find value and confidence in what we do. So that being said, my fellow data managers, what do I think are our biggest obstacles? From my point of view, this is where I believe we place undue pressure on ourselves as data managers. This is where it arises from. It's from making ourselves too responsible for factors we do not or cannot control and not maybe focusing on enough of what we can. Many of us get frustrated if we are missing ECOGs, PFTs, perfusion records. And the last thing we want to do is leave a field blank. Allowing the pressures we place on ourselves to blind us to the pressures that those we partner with face. And in this particular talk, I'm specifically referring not only to the STFs, because they themselves have a unique set of pressures that they need to focus on in order to make sure that the registry functions the way it's supposed to and that they can support and resource us appropriately, but also the surgeons. When we do this though, and we place all this pressure on ourselves or blind it, we can make things feel personal, like we ourselves are being attacked, as all three of us kind of in a symbiotic entity are trying to work together in order to essentially make the patient outcomes better, the database function better, and allow our surgeons to improve their care. Another one I think we do, and this one really kind of pertains mostly to, I think, our female data managers, is that we are constantly, women and especially have a tendency to want to be everything to everybody, everywhere, all at once. And especially when we are getting emails from fellows, or, hey, we just brought on a new resident and he's so interested in research. And hey, here's our data manager. You can hook up with them, another project. Oh, we have another quality project. Now the administrators would like you to pull this data or make this presentation or come to this meeting. Sometimes we feel like we are getting everything from everybody. And it can be exhausting and it can make the job feel a lot more stressful than I think we need it to be, because obviously what we do comes with enough of its own stress. So sometimes in that regard, we just have to learn to say no, or to that specific project needs to wait, or will require more time, or require more FTEs and staff. So when we look at these strategies, I believe that these are the ones that help mitigate these pressures and make the job we do more enjoyable and less stressful overall. Taking our time and stepping back sometimes to understand the pressures and situations that each entity in our interdependent relationship faces, owning our own responsibilities and leaving the responsibilities that the STS and the surgeons have to them to the best of their ability and to the best of ours, really trying to separate that out and know what we own and what they need to own. One of my favorites, striving for excellence in accuracy and not perfection. My guess is a lot of us came from ICU settings where anything less than perfection is unacceptable in patient care. A lot of us have very, very type A personalities, and sometimes I think we, and I know for myself, can conflate perfection with accuracy. It's definitely something I struggle with even 7 years into this job. Not taking anything personally when these things are not necessarily personally directed at us or our ability or our skills, and bringing the receipts. So in owning our own responsibilities and understanding the pressures and situations that each of the people involved in this piece of the puzzle is basically, it's just it's owning our own responsibilities and leaving the STSs and the surgeons up to them. And what are those situations? Oh, I'm sorry. I went to the wrong slide. I'm going to talk about that in a minute. I apologize. Understanding the unique pressures and situations that each of us face. I know personally from working on the core group and kind of seeing some of the behind the scenes and seeing how hard everybody works. I'm on the monthly calls with Eddie. I know he works with the general thoracic as much as doing a ton of work for the adult cardiac. He's so deeply committed. And I know that Carol in the adult cardiac from the STS is deeply committed to really trying to understand both the needs of the surgeons, what the database is trying to accomplish, and also help and support the data managers. It's a tough job. I've seen it from, behind the curtain, and I really deeply respect them a lot for having been able to do that, have a greater understanding of maybe when my FAQ was not getting answered as fast as I would like it to get answered, and how backed up they get, how many questions they are trying to answer, things of that nature. It's really helped me kind of detach and stop maybe stressing about something that I don't necessarily need to stress about. And also just remembering how much the surgeons are doing. I often, when my surgeon comes blazing into an email or a text message at 4 a.m. that he needs something or she needs something or we need to pull this report, that they are doing a ton. Between actual surgeries, dictation, rounding, clinic, fellowship, like teaching the fellows, submitting papers, consults in the hospital, they're most likely getting harassed by the hospital's clinical documentation team for reimbursement purposes. which is a lot of where the complications arguments come from, if that's just my personal opinion. But just remembering how much they do, and it helps me kind of take a step back and remember that they're not trying to overburden me. Their brains are just working on, like, they're just working at a different pace and in a different frame than mine are. And sometimes, though, my responsibility is I have to remind them of that. I have to say, hey, listen, I've got these other projects in a queue. And so I know you need this right now, but like, what's the absolute, like, what's the, if you're not going to get this, you're going to die date, you know? So we can kind of figure out a plan that manages the priority and gets them what they need when they need it. Because we all know how much we're doing, but are we communicating to our surgeon teams, our surgeon leaders, and our administration that same thing? Do they know how much they're doing, right? A lot of times, a lot of this, like, we kind of, as non-clinical employees, get put on the back burner because we don't generate RVUs or we're not clinic facing. And so it can sometimes be lost without us communicating ourselves how much we're actually doing, or how much this is piling up, or what kind of bandwidth we actually have, and if we need more support, if the hospital actually wants to run a competent and effective clinical, like, quality program. So I think that a lot of the complications in this too, where we're managing our own expectations and helping others manage the expectations of us, is that those surgeons who are less involved in the actual data or with the STS database, they don't actually understand how much goes into what we are doing and how to find these data definitions, or where this information is at, or why it's difficult in the clinical documentation. Like, they really don't understand the amount of work hours that goes into abstraction, putting together, depending on your vendor software, you know, how pulling reports is, running all this. Like, my surgeons, because of the way that Intermax is set up, they have no idea how much of that ends up being manual, because that database is just not really set up, and the abstraction and data submission platform for Intermax is not really set up for, like, quick reporting in the way that we do it. So, you know, they need a constant reminder of, like, hey, this is going to take me a full day to input all of this into what you want, or building out other things for them. So I think a lot of the lack of understanding from us too comes from not just explaining, hey, this is how these databases work. This is how often the data comes in. This is what it looks like, because they themselves are just further in proximity to how these databases function and what is the reality of our day-to-day. You know, they don't see a complication until we've collected it. And then they don't like it, and then they want to talk about it. Then they want to get all in the weeds about the data. Then we show it to them, and then they back up real quick. It's usually what I've experienced. They might ask also just not understand that the definitions change, or some of the other things. So I think for us, the most successful approach is just remembering where we're all coming from, so that it can be a more harmonious relationship when some of these issues come up. Owning our own responsibilities and leaving the SPSs and surgeons to them. In my opinion, this is what I believe each group is responsible for. Data managers, we are responsible for consistent and accurate data abstraction, clarifying data elements with the training manual updates and the FAQs, and partnering with our surgeons regularly so that they do have a pulse on what our data looks like, or what abstraction is like, where fallouts might be occurring, so that them and the clinical team, or they can champion to the clinical team to make documentation changes in real time. The surgeons, from my perspective, well, they're responsible for performing the surgeries, consistently and adequately documenting and ensuring that their team is also doing the same thing, clarifying certain or unclear or missing data elements that we are finding fallouts in our abstraction in our cases. And they're responsible also, not just us, but them reaching out and partnering with the data managers regularly. The STS is responsible for maintaining the accuracy and integrity of the database. Their annual audits, which, gosh, I can't imagine how much that work all is. Updating and redefining the data collection form versions, and clarifying field definitions, and of course, taking all of our FAQs and updating all of our data manager resources. And all of this is just remembering we're all going for the same thing. We all have the same goal, which is improving our patient care, minimizing complications, making everything better for the people that we're performing surgery on, and being able to utilize that data to further improve their outcomes as the length of this database and registry continue on. So, striving for excellence and accuracy without perfection. I can show my surgeons where we have holes in our documentation or where we're missing data elements related to that documentation or from other departments. But ultimately, I have no say or control over if those things get rectified in the future. And this is definitely one that I've seen is one of the more frustrating parts of being a data manager, and where I see other data managers, especially in thoracic, get very frustrated. It's like, oh my gosh, they're just not documenting this, or I can't find it, right? Like, no one's willing to document PFTs, but then they're coming to you and being like, I can't believe that's a prolonged event. I know that patient had COPD or chronic lung disease. Well, if I don't have an FEV or a DLCO to show it, and you didn't order them, I don't know what to tell you. We can't do anything about it. So for me, it's been a long practice of realizing that I can't control those things, and I also refuse to drag anyone anywhere. If they get rectified, great. But if they don't, I basically have to do two things: put it in my balloon and let it go. If they're not willing to make the changes, or the administration is not willing to support what changes need to be made so that this data is more accurate, then so be it. There's only so much I can personally do in one day, or my team can do. Now, what I also do, though, is that goes into what I talked about, not taking things personally, but I do my best to keep logs or receipts of what we're missing and why we're missing. And so when we get audited, that way, when they come to me and they ask me, and because they're busy and they have a ton going on and their brain's going in a bunch of different directions, just like ours, I can at any given time be able to discuss these data elements or these fallouts and say and show, hey, I did try to rectify these. You know, specifically for me in the thoracic database, we have an issue with ECOG scores, not putting ECOG scores in or not being able to find them. And so when they're like, oh my gosh, why don't we have these ECOGs? I'm like, well, remember, I sent you an email with all the patients who didn't have ECOGs, and you guys did not get back to me. So this is why. These are fallouts. Same thing, let's say with the Intermax database, or with, I don't have a lot of problems in my cardiac database like I used to with cardiac rehab and stuff, but Intermax, no one wants to put anyone in the intermediate ICU. Everyone's in an ICU until they get discharged. So even though I brought it up and I'm like, hey, if you might want to think about downgrading your patient status, even if they're in ICU, to IMCU or intermediate, it's still a 5-year fight. No one's done it. So everyone's got ICU days from implant to discharge. And if they're fine with it, I have to be fine with it at the end of the day. So that's how I work on not taking it personally. And every time, yeah, I bring the receipt. And the other thing I do is I bring the receipts. I do everything in my power to gather the most accurate data I can. We, as data managers, are always trying to extract the most accurate data every time we extract a case. But at the end of the day, we are beholden to the definitions of the data field elements, not our surgeon's opinion of them. So if you have a patient that's post-operatively febrile, has leukocytosis, was placed on antibiotics, the radiologist dictates that there's a consolidation in the lungs, most indicative of pneumonia, and your surgeon says, I don't think that's a pneumonia. Too bad, so sad, that is a pneumonia per the definition in the training manual, right? So if they come to me and they're like, I don't agree with this, I will pull up and I will screenshot to them the data, the training manual. I will screenshot to them the clarification and intention of the data field. Like, this is the database you want to participate in. This is the definition. This is why it meets this definition. So then I'm able to bring the receipts, but I'm able to do it in a way, and this to me is one of the most important concepts, is that way I'm not feeling overwhelmed in these moments like they're personally attacking me, but I'm able to point to what we're both working towards together. Like, you want to be in this database, I'm here to make you successful. We're both trying to make the patient outcomes better. You know, I obviously, like, I'm reminding them I'm on your team, and some of their pressure comes from what they're getting from administration, what they're getting from clinical documentation based on CMS requirements and reimbursement, right? Like, you always have to keep that in the back of your mind, those pressures that they're getting and why they kind of knee jerk to be like, this isn't a complication. And what I do when I do this, it allows me to kind of cool it off and be like, it's not me against you. It's what's documented versus the definition that we are seeking. That's it. It's the documentation versus the definition. And when we I find that when I approach it that way, it kind of takes the heat and the pressure off, not only for my surgeons, but also for me. Like, hey, this is just what we've got and what we're looking at. So, you know, if you as a data manager are regularly checking your abstraction against the training manual and FAQs, you should be able to easily and impartially show your team why these complications are what they are. And it is hard to do sometimes. You know, I have a surgeon, I have a couple of them who they're notifying me of the most recent star ratings when it's been out for 30 seconds. And they're already wanting me to dig into everything, and they want me to look over every single complication that came in, anything that, you know, messed with that hurt specific quality domain. Mortalities are a little more obvious, clearly, but, you know, oh, please go back and look at every prolonged event. Please go look back at this. How did this happen? Right. And so this allows me to take a step back when I'm getting when I'm feeling those immense pressures, and just realize, look, they want to make sure they're doing the best job that they are doing, and that they are also making sure that the documentation is accurate, just from their standpoint too. We're both trying to accomplish the same thing. We're all trying to accomplish the same thing. And so not taking things personally while also providing the receipts is definitely a skill that I've had to grow in this role. It's just, I have to remember my surgeons, you know, they're not always looking at this data as granularly as me. And so since I've got my finger on it all the time, like, I'm like, oh yeah, well, yeah, of course, you know, you had 2 renal dysfunctions and 3 post-op events, but they're like, what? We didn't have any. But they also, you know, my thoracic surgeons, they think they do 3,000 lobectomies a year sometimes. Or my cardiac surgeons are like, we did way more cases. I'm like, no, bro, you're at 3 different hospitals. Like, this is just the one. So it's just, I remind myself that while I'm begrudgingly asked to go back to work on some of these things, it's because I know that in their heart, they really are trying to do the best job possible. And I think by looking at it this way, it overall strengthens the trust we have in our working relationship, and thus allows us both to do our jobs better with mutual respect for one another's roles. Speaking of prolonged events, this is actual footage of me showing my surgeon that they extubated that patient at 24.5 hours post-op from the OR exit. And that patient who came in with a nosebleed, who now complicates, or now counts as a bleeding complication. But I will say too, you know, my surgeons have also found errors and discrepancies in what I've done. And so they sometimes bring me the receipts, and I have to sometimes eat some humble pie. And it's definitely humbled me and kept me on my toes, that I need to make sure, you know, to be looking for what I'm missing, and that I also am not perfect, and that I can improve and learn how to do things better as well when they come to me with areas that they may see improvement in. I just always constantly look at this as a two-way street, and that we're always we always have the same vision in mind. We're always working and striving to make our patients better. And so what this really comes down to is basically what I said in the beginning, is that we as data managers, our surgeon leaders, and the clinical teams we work with, and the STF database, both can accomplish what the database is setting out to do, the registry is setting out to do, through the recipe of mutual understanding, mutual respect, and mutual accountability, so that we can continue to make this database one of the best in the world. We can continue to improve all of our patients' outcomes, and we can work to make our jobs more efficient, less stressful, and more enjoyable, because I do think this is a really great job for so many different people, and I think it's one of the most fun jobs I've had. So that's my talk. Questions?
Karen, it's Judy. That was awesome. I think it spoke to a lot of our hearts here. I will say for adult cardiac surgery, Melinda, definitely, and I think this was part at AQO, like we do have to have the provider documentation. The training manual actually says physician, but I know we have a lot of advanced practice providers. So I'm assuming that counts. Callie, you might be able to speak to that, but that was a great talk. And my question for you is, how did you adjust to leaving the bedside and leaving, touching patients, caring for patients, to this role that's so far away from clinical care?
Oh man, it's let me answer the first question you have when you said provider documentation. I will challenge that, and we often do in thoracic, but it's like, yes, like I guess the point in that, and I think the discussion we always have, like I was just using the pneumonia example where it's like documentation by a physician. It's like, well, an infectious disease doctor is a physician. It doesn't just have to come from the surgeon. I think that's one of the hangups we end up having, and we see FAQs about that frequently. It's like, well, where does the documentation and either clarification in the training manual or just clarification to the data managers, like where does the physician documentation come from, and who are the physicians that can have that documentation? Just speaking to that one, I just always give the pneumonia question, because we do get a lot we get a lot in the thoracic registry where like literally it checks like every single box of pneumonia. Like the patient could have positive sputum cultures, and we'll inevitably get a question from a data manager who's like, but the surgeon said that they didn't think it was a pneumonia, so it shouldn't count. We're like, no, that's a pneumonia. We don't, my surgeons will tell me, my thoracic surgeon's so honest. He's the task group. He's the core, I think he's the head of the surgeon task force, but he's like, this is why we don't do our own data, because we'd never have any complications, because they'd weasel their way out of all of them. So yeah, that's an ongoing battle, I think, in all of the databases. In terms of how I transitioned or how I was able to talk, or I don't know, like cope. I've been a nurse for 20 years. I love it. I went into it because I was sick all this time as a kid, and I had amazing nurses. And so it was the right move for me, in terms of I had one little boy and one on the way. So moving to a non-clinical position was a logistical move at the time that made sense for me and my family, given my husband's job. But I was always so sad to move away from the bedside. I think what I really like about this role is, even though it's physically removed, like I'm digging in charts every day. I get to see everybody's story. I get to kind of ride the role, like that still lets my brain work, or lets me kind of ride that clinical roller coaster where I'm like, oh yeah, they came in. Like I get to read everything and see how it goes. So I still have a hand in the chart. That makes me still feel connected. If I have a cardiac patient or a VAD patient, or even thoracic, right, and they end up on ECMO, there's a part of me that still goes to the ECMO flow sheet and is like, well, let's see how everything's going. You know, like what's the oxygenation at? Like how are the pressures?
Which
I
is
like
sweet.
that part of me. Yeah, it's hard. It's still hard. I still kind of, when I go through my charts, still feel sad when a patient expires or didn't make it, and sit and think about them. So I don't feel completely emotionally removed. I feel removed from more of the like frustrating, the things that used to annoy me about bedside, but I do miss a lot of the clinical aspects. I am lucky in my neighborhood. I have a lot of kids in my block. So I still get to, I say like, I still get to be a nurse because I have friends who are like, hey, this is going on. What do I need to do? How do I give time?
Mhm.
Like, what should I do? My kid has 103 fever. I've got a hemophiliac on my block. The mom's like, can you come over and infuse factor nine? Or I think he's factor nine or factor eight. He's factor eight. So I still get to do that. I had a friend come over who receives testosterone shots and he needed to be taught. So I still got to give him testosterone shots. So it's funny, nursing still works its way into my life in lovely ways. And I love that. But this was a good move and the right move. And I think maybe in the future when my kids are older and I move to like a part-time or a per diem, I could see myself going back to like a level 2 NICU or like doing 1 day a week clinically because I do miss it.
Thank you, Erin. That was awesome. Any other questions for Erin? And I don't know if you can see the chat, but you got some nice compliments from
Oh, thank you
Maggie and
guys.
Callie. And it's the second time they've heard you, and they enjoyed it the second time too, which I think is a testimony to how much you're speaking to us. And Vicky says, "Oh my goodness, are you speaking to me? Like she's afraid to take PTO." So like I think you really spoke to our
Yes.
hearts. Do you work remotely? That's one of my other questions, and I hate to be the one asking them all, but how do you get support? Like, do you work remotely? And I know it sounds like you have a nice neighborhood, but getting that support and, the friendship and the just emotional support of people who like get what you're going through, like every word you spoke to us,
Yeah.
like we all relate to and understand. Like, how do you handle that in your life?
That is a good, so again, it's almost easier because I am more removed. Like when I was coming home and like, crying over a kid or an adult or, a tough ECMO case, like I almost had less people who could relate to me. Like, or they were like scared to hear it. That's like as a nurse, such a complicated thing. The support I get now, like it's weird. I am remote. I am fully remote. My hospital is constantly running out of office space and I was constantly getting shuffled around but even before the pandemic, I'm like, let me just do you all a favor. I will just move to my house. And so, I guess I don't seek it at work as much. And having been there, I'm in an academic medical institution. So for me, there's a ton of turnover. I've been here 20 years. I've seen a million people. So I guess I just seek it out in other ways. If I have, if I need support in terms of like frustration or issues with like database specific, other data managers, core group members. I do have some great teammates in the hospital that I can absolutely message with or text. Um, so that's kind of where I get it. I don't need it in terms of clinical care like I once did. But it is funny. I think I told you this. Like when I'm in my house and I'm raging about, like some data field isn't loading from the third party software vendor before the submission deadline. And I'm like, you gotta fix this. And I'm like, fighting with IT or whatever. Like it just doesn't land the same definitely with my husband who doesn't understand anything I'm talking about, you know? So it's weird. It's really just other data managers. And there are so many wonderful groups like this one, the regional groups, AQO, and any of the, like, there's a regional one for Illinois for cardiac surgery, and everyone on there is so helpful and wonderful. If I needed to spitball with somebody or pick somebody's brain or just vent or whatever, like, everyone's so forthright with, hey, yeah, go ahead and email me or call me or whatever. So that's always so nice. I think data managers in general, even though most of us are spread out throughout the country, are very supportive. of each other, which is so, so nice.
Erin, thank you so much for joining us. I know this was a busy day for you, and we so appreciate you taking your time out to share with
Glad
us.
to do it. Glad everybody could feel seen and understood.
Absolutely. Thank you.
Thank you.
Eddie, do you want to move us along?
Yeah, thank you again, Aaron. So we were scheduled to have a break from 1:45 to 2. Do folks want to just take a couple of minutes, or should we jump into our next presentation?
People want to chat in. Amber, are you able to stay on?
Absolutely.
Are people okay to move on? Can you give me a thumbs up or? Why don't we go ahead and move on then? Nobody is against it, it seems.
Sounds good to me. Well,
Sorry, I wasn't watching my time schedule here, Libby.
no, it's all good. Always great to have the discussion here. So, up next, Judy, would you like to introduce Amber?
I would love to introduce Amber. I've had the privilege of getting to know Amber because she's working with us at UVA with our biome analytics, and we got biome, and she'll tell you what it is, but we're kind of new clients, so I think we're still getting our feet underneath us. But one of the things, and I tell Amber and her group this all the time, is that this was a product that I felt like, and of course, I always think of like Sheila at Armis, like, you go to Health Catalyst, right? Like you think you get people with a product. But I just have to say that team has just been so open and willing to help us with our interactions with them. I have any questions, they're there, and they're very open to feedback and giving us help. And Amber's been kind of the lead of that for us in our contract with them. And Biome takes our STS data and ingest our financial data and kind of marries the two together. So she's going to tell you what it is. And maybe I could talk a little bit afterwards if you need me to, Amber. I don't know. We'll try to get 5 minutes in here for people to take a break, but you go ahead, Amber, and you can tell us who you are.
Sounds fantastic. Can you just validate you can see my screen okay and that you can hear me okay?
I can see your screen and I can hear you.
Great. Thank you so much. Okay, well, I appreciate the introduction. I'll do brief introductions of both myself and Stuart, and then I have lots of information about this presentation. I know that there's a few of you who actually work with us here at Biome on the call. So as I move through the presentation, if you have anything to add, or we can save some time for that in the end, we'd love to hear your feedback or your thoughts around this as well. Just to do brief introductions, my name is Amber Polakowski. I'm the Vice President of Performance Improvement here at Biome. As Judy mentioned, I have the pleasure of working with several folks on the phone and leading the engagements across the medical centers. I'm a critical care nurse by background as well. I loved the previous presentation. I just caught the tail end, but the part about moving away from the bedside and kind of doing the data piece of this really resonated with me. I think you summed it up perfectly about the things you miss and the things that you don't miss. So anyways, I have, as I mentioned, the pleasure of leading performance improvement across the hospitals that we engage with, along with my entire team of performance improvement consultants. And then I'm joined by Stuart. So Stuart, I'll let you introduce yourself and then I'll move into the presentation as well.
Well, it's a pleasure to meet everyone. I'm here in Charlottesville, and it's a great honor to serve UVA. And we founded Biome about 8 or 9 years ago. We might have just hit one of the highlights of my career at Biome today, actually, which was if you look at Becker's, you'll see a success story that UCLA published about what they've achieved in cardiac surgery and other CV subspecialties. And I guess that's hot off the press, and it's a great pleasure to be here. I've known Eddie. I met Eddie probably 8 or 9 years ago and have deep respect for what he and his family have done to move both this organization and the field along, and it's a great honor to be here and a pleasure to be here. So Amber is much better at all this than I am. I'm more of a data geek, but Amber, I will let you take it over.
Sounds fantastic. And Stuart did mention, but we're both local in Virginia. So Stuart's in Charlottesville and I am in Norfolk, Virginia. So what we'll plan to cover today throughout this presentation, we'll start with kind of a high-level overview of biome and what we do, what data sources we utilize. Of course, I think the most exciting and some of the case studies and impact that we've helped several hospitals across the country achieve. Talk about kind of the full engagement, and then of course at the end, hopefully have some time for questions and answers as well. So the first thing we'll just note here again, what do we do at Biome? So there's a couple of key points that I have summarized here just to give you a high-level overview of exactly what we do. So we are a cardiovascular performance improvement solution. So all of the tools that we have across the Biome Performance Network are really targeted and focused on helping hospitals improve around cardiovascular performance. And of course, here specifically, we're talking about that STS, that cardiac surgery data. So the few buckets that I'll talk about, and then we'll go into a lot of detail here, but first is driving high yield quality projects, sharing best practices from sites across the country, creating those efficiencies and capacities to help programs grow, improving margins and profitability, and then really helping to enhance documentation and risk capture through some of our audit tools that we offer in our application. You'll note across the United States, we serve several healthcare systems that are just a couple of samples that are listed here. We support both academic medical facilities, community hospitals, again, tertiary referral centers. And you can see, I know there's a couple of folks on the line. I recognize some names. I won't call everybody out, but I did recognize some names on the line for some of our current clients that are on this call today. We do have a very large database of both hospitals that are in that database, and then also, of course, patients and procedures. That's really important because as we talk about sort of what we offer and what we do, having that really robust percentage of procedures in our database allows us to do benchmarking and cohorting at a few different levels. So one is, of course, at that hospital level, how do you compare to the Biome database in general in terms of performance for a measure? We can also do this at the like hospital level. So in terms of comparing you against similar risk profile hospitals, comparing you against other teaching hospitals, non-teaching hospitals. Then we also do benchmarking down to the patient cohort level. So as an example, if you wanted to see performance for a specific measure, we'll pick on 30-day readmissions for your isolated CABG population. We can actually show you what that looks like, let's say for a patient population like your Medicare only patients, and then we can help you benchmark that across other hospitals. So what do other hospitals, like hospitals look like in terms of that percentage of 30-day readmissions for your ISO-CAB patient population and just the Medicare patient population. So having that really robust platform with both hospital centers and then patients and procedures as well really helps us to offer some of that granular subcohort analyses. So the big question that always comes in is, what data sources do we utilize? We use two main data sources at Biome. The first one we'll talk about here, of course, everyone on this call is very familiar with that STS adult cardiac surgery data. So we use that full harvest file. The second piece of that is your cardiovascular, administrative, and financial data. This comes to us directly from our individual sites, and we utilize that data. We marry that data with the registry data to create all of the insights and to really leverage the tools that we have on our Biome Performance Network. Now, the administrative and financial data feed, of course, all those elements that you traditionally think of when we think of an admin file, things like ICD-10 and payer and DRGs are all included in that data. But we also get very granular direct costs. We also get indirect cost data, but we actually get supply costs as well. So for example, in one of your isolated CABG cases, not only are we going to be able to see things like net revenue and what ICD-10 codes were billed in DRGs, but we actually can get charge capture data. So we can see what types of sternal plates were used, different medications or devices that might have been utilized within the case. So again, we're able to roll that up at a very high level for the financial data, but then also down to the individual line items that are utilized in a case or throughout the patient's stay. Merging these two data sets together allows us really to understand things like clinical outcomes and also financial and administrative outcomes in the context of that very rich clinical data. So for example, if we're looking across sites, we might be interested in understanding differences in, direct cost per case for, let's say a single vessel CABG or things like that. But what we're actually able to do is also marry in that clinical data to really understand risk and other things that might influence cost. So having those two data sources kind of speak to each other is really essential to everything that we do at Biome. So with that, you'll see kind of how our solutions work. So I mentioned to you that we bring those two data sources together. We use, again, the clinical, financial, and operational data. We take our data models, we unify all that data together, and that's what produces our Biome Performance Network, which really consists of our entire suite of performance applications. You'll see those core products, the Opportunity Engine, Performance Manager, and Analytic Engine, which I'll talk in a little bit more detail about. But all of the data sources that I showed you previously, we bring those data sources together to produce that Biome Performance Network, which we use every single day to, again, support healthcare systems across the country and leading performance improvement work. So within that performance suite, we have 3 core products that I mentioned. I'll also talk a little bit about our risk audits here as well. But the Opportunity Engine allows you to sort and rank opportunities across the entire service line. So again, as we mentioned, and as you all are very well aware, of course, there's clinical measures that are very important to us, things like rapid extubation, prolonged ventilation times, re-op, all of those measures that we know are very important to understand, to maintain, and to ensure they're at the top of our radar. The other things that we can help with are those financial measures. So understanding performance in terms of contribution margins or direct cost per case, those sorts of things. Also, we know, operational data as well. So length of stay, ICU time, all of those types of measures. And our opportunity engine, all of those measures are brought together, and we can help you sort and rank opportunities. In other words, where do you have the most room for improvement compared to the Biome 50th percentile or to one of the national registry benchmarks? By bringing that data together, again, it allows you to, in one unified location, sort and rank and stack opportunities by things like cost savings, or again, differential from the Biome 50th percentile. Where do we see large areas of physician variation? Then we take those measures and we actually move to the Analytic Engine, which is where you can explore and test very granular hypotheses. So as an example, we might think that for rapid extubation, there's going to be a difference by the time the patient leaves the OR. Our hypothesis may be that patients that leave the OR before 7 p.m. have a higher percentage of rapid extubation than those that leave the OR after 7 p.m. or things like that. You can slice and dice that data very granularly in the Analytic Engine. And then finally, the Performance Manager, which is basically a completely customizable A3. So you can go in, customize measures. If you wanted to work on rapid extubation, you can set custom targets. Every single time the data is submitted to us, those will automatically update, and it will also help you quantify the impact in terms of bed day savings, patient impact, and then any cost saved related to a specific measure. So you'll see here just a couple of ways, and I won't go over all this in detail because I really want to spend time on the case studies. But how do our teams that we work with across the country leverage our solutions? You'll see here, one, being able to help control that financial narrative, lots of support around research requests, utilizing, again, that robust data to help support research requests within the organization, across organizations, rapid data insights, again, immediate access to getting answers to those questions about operational, financial, and clinical data, bridging that clinical and financial data together, advanced benchmarking, reducing variability, and then really, helping to kind of streamline those analyses so it doesn't take quite as many resources to, again, pull data together across various platforms or different, reports that the data might be coming to us. So with that, better than, me talking about the application is really going into some of these data-driven success stories that we're able to share from some of our clients who have really been amazing and allowing us to share the data and the outcomes with you all here. So as Stuart mentioned, actually, right before we got on this call today, we got a notification that the UC Consortium had published a article about some of the joint improvements that we've made across clinical, operational, and financial data. So we were really excited about that. I was going to link it in here. I just didn't have time before we jumped on the call. But this is showing you, some of you may have been present at the Advances in Quality and Outcomes Data Manager meeting last September in Nashville. But this presentation was presented there, this poster. Again, this comes out of the University of California, where we've been supporting for almost the last decade, really helping the cardiac surgeons, the quality managers, the administrative teams there leverage the data both in financial and the clinical quality data to help stand up some of these improvement projects. You'll see here that there are statistically improved outcomes across several areas, including early extubation, decreased blood utilization, reducing readmissions. over $14 million in margin improvement across those UC centers and over 1,000 bed days saved. Again, we meet with them very regularly. Typically, we're meeting with the centers monthly, going over this data, sharing best practices across the consortium, very much similar to some of the work that I know you all are doing here. And with that, again, we've been able to measure and really document and show the improvements, both in patient impact, and then you can see cost and bed day savings as well. Next is Barnes Jewish Hospital. So Wash U, again, a very engaged team in St. Louis. We've worked with them across several clinical areas. This particular case study that I have linked, and I do have the full case studies here if you're interested in how we accomplish some of these items. I'm happy to share all this as well. But you can see really worked very closely with their team to reduce acute kidney injury in cardiovascular patients. The average savings for that, depending on the presentation for the patient, is anywhere from $17,000 to $41,000. Again, improving cost savings while improving outcomes and reducing AKI. There are a couple of novel strategies that were implemented there, including the use of an automated personalized contrast calculator that was implemented in Epic. And you can see, really, we've worked very closely hand in hand with them to not only ensure that this is continually done and implemented, but also prove that ROI, which helps to justify not only the ongoing partnership, but also additional resources that might be needed or utilized to continue to drive improvement across the cardiovascular service line. We know here at Biome that quality is the right thing to do for our patients, of course, but also, from a business standpoint and from ensuring that we are delivering care, the highest quality care at the lowest cost. Quality is also a really important lens through which we do that as well. So being able to quantify that and ensure that we're showing the impact in terms of dollars and cents for quality improvement is a really important part of what we do. Up next, Trinity Health. Again, as I mentioned, I showed you a couple of the academic medical facilities that we support. Trinity Health is one of our partners, a system partner. We specifically work with several of the hospitals in that system. One of the large community hospitals that we support is called St. Alphonsus Regional Medical Center. And you can see we've partnered with them across the entire cardiovascular service line to really help them ensure that, one, they're consistently ranking as a top decile performance across their cardiovascular metrics, helping them with things like accreditation, really focusing on risk capture, adequate documentation. We support their co-management monitoring and tracking through the performance manager. So again, they're utilizing that to measure their co-management measures that they've developed with their physician leadership to ensure that those quality measures are being incentivized in the right way. And then again, really aligning the incentives between the hospital and the physician contracting. We've done some advanced financial analyses for them, again, looking at things like cost per case and understanding, is there variation in some of the very high line item cost items across the OR procedures. And then, of course, we're really helping them stand up some of the accreditation management that they're doing with their chest pain patients in the service line there. And then one other thing that I'll just mention here, this is actually a full presentation through the Cardiovascular Trends Forum that we did with Robert Wood Johnson University Hospital. You can see that we've worked with them very closely, Dr. Russo, Megan Smith from the program there, to improve in several areas. The first is improved risk capture. So they do a lot of urgent cases in their center. We're having had some opportunity around capturing STS risk score. We significantly decreased the percentage of cases without STS risk score. That's now less than 2%. A significant reduction in vascular complications, improvements in procedure times, and then increased extubation in the OR. They have greater than 80% of their cases that are now extubated within 6 hours. Again, really help them with some of the direct cost per case data, adding additional capacity for their procedural growth. And then one of the big ways that they've leveraged our data, it's really interesting to hear how they talk about this, because it's something that as a nurse, I don't think I had a true appreciation for, but they really utilize the data to secure an ongoing commitment from the C-suite to support further program investment. So making sure that the case is there to always support that cardiac surgery program, because again, they have the quality and they have the cost data to be able to do that and to make that case for further investments in their service line. And then finally, I'll mention one other thing here. And I know, Judy, you might have some thoughts about this as well, and I'd love to hear from you on this. But one of our other things that we focus a lot of time on is our Biome risk audit. So because we have two distinct sources of data that we can compare and contrast, we actually take the administrative data and we take the clinical registry data and we do a comparison. And we say, are there risk variables that are captured in the admin data that we don't see captured in the risk data, either from the registry or, you know, whatever we're looking at there. That's really important for a few reasons. One is, of course, we always want to make sure that the risk is accurate due to things like case mix index and the way that you're, you know, reimbursed from the hospital. Of course, from the STS standpoint, we want to ensure that you're adequately capturing your risk, you know, one, to ensure that the risk of your program is being reflected, but two, all of those observed to expected or risk adjusted measures, very important to be able to make sure that you are, you know, accurately capturing that every single time you have an opportunity to. So by doing that comparative analysis, we can actually create flags to say, okay, here are, you know, 10 patients in the last quarter of data in which we saw that there is something like heart failure documented in your admin data that we do not see in your registry data. And with that, what we're able to do, again, the folks at the hospital sites actually go in and they're able to adjudicate that data. And you can see here, this is blinded data, but significant improvements in terms of capturing risk with these risk audits. And with that, again, as we see that predicted risk of mortality increase, we've noted at several of our centers across our database, a corresponding decrease in things like the ODE mortality, AKI, bleeding, those types of measures. So again, a lot of work that we do, as I mentioned, around documentation capture and ensuring that the risk audits and all the documentation opportunities are addressed early in the engagement. Finally, you'll see just some deliverables that are empowered by our services. Again, all of these items here, those push reports, full access to the product suite. You know, we really help support reviewing the data regularly, whether that's monthly or quarterly. And of course, as Judy mentioned, lots of bi-directional feedback and ad hoc reporting. So if you have a question about something in your data, instead of spending, you know, 2 days trying to get an answer, sending that over to our team, we're happy to put together custom analyses, you know, send those back to the centers and say, here's what we put together. Let us know what additional questions you have. Again, really our whole job is to make your life as the quality manager much more easy and be able to answer any questions that you have regarding the operational, clinical, or financial data. And then finally, just in terms of a timeline, one other question that we get very often is, what does this look like in terms of integration, and how long does something like this take to really get up and running? So the beauty of it is that we utilize flat file transfer. So any of the data that's submitted to us, either by the clinical team, is just the harvest data. We take that as a 1-for-1. And then again, that flat file that comes from the administrative and financial team. Really getting that data, synthesizing that data together, that takes typically about 2 weeks for us to get the data, do all the QA, process that, and have that full application up and running for your team. The first 3 months of engagement, we like to spend time really, you know, socializing the data, making sure everyone understands the data that we're presenting, identifying opportunities. And then over the course of the engagement for the next, you know, 6 to 12 months, we like to have, one, identified the opportunities that we're going to work on together. And then two, really start to refine those with some of that hypothesis testing and starting to kind of work through that PDSA cycle on the opportunities that we're going to focus on and really start to narrow that down, kick off some PI work groups. So that's sort of what that engagement looks like. Again, a pretty low lift from an IT standpoint, which is of course intentional because as we all know, working in hospitals, it can be, you know, there are challenges, of course, when you're hoping to get something like an IT integration because that team is being asked to do things across the entire hospital, right? So there's lots of competing priorities there. So again, our intention is to make that IT lift as low as possible. Now, finally, just one other quick note that often comes up is, so what does this look like in terms of the engagement and how do we ensure that we're driving quality and that we're measuring that improvement? And you can see, again, this just is meant to really show what that looks like. So we recognize that, you know, if we're coming into an organization, we really want to understand what are the opportunities at a high level that we can help to support. And again, those ad hoc, the data analyses and participation in those quality meetings. But then again, moving forward, we like to make sure we always keep a finger on the pulse of what's happening in the engagement. So, you know, something like identifying an opportunity early is great, but we want to make sure as we move throughout the engagement that we're also continuing to say, okay, here's an area that we see you're getting better. Here's an area where you know, we see that there may be some regressions, and all of our tools are built to automatically do that for you. Again, as I already mentioned with our performance manager, we can also help to quantify impact in terms of bed day savings, ROI, and patient impacted, which is extremely important. Obviously, there's such a huge commitment to quality, and many people are working on these projects across service lines across the country, but being able to quantify that is extremely important, again, to make sure that those the ongoing investment for continuing to invest in quality is there. And again, to do that, you really need the business case to support it. So that's how we do that with our Biome annual strategic roadmaps. So with that, I want to just pause for a second. I want to be mindful of time here. I'm curious, Judy, do you have anything that I missed or I didn't hit on that you think I should have, knowing that, again, you're a newer client, but I think you've been just such a super user of our product suite. So I'm interested if you have any thoughts.
Well, the risk audit hurt my feelings so bad. Because you think, and so what that did is it took the billing data and a lot of things I couldn't take. The STS definition is going to be different. But I had missed like 6 or 7 for calendar year 2024. I just hadn't seen them or whatever. I didn't put the date range in right. And like I had PFTs with an FEV1 of 38 and like totally didn't have it in a record. Totally did. I mean, that's severe COPD, right? So like I kind of have to go back to Erin's talk where it's like, okay, it's not personal. You're not perfect. You have to accept the fact you're not perfect. You're going to mess up. Like, and it's been helpful. It's also interesting to see where coding gets some of the things, that I really like. They're like, if I got audited, they are not there. And I can say that. It's interesting in the software. I can say rejected, or I can say accepted and changed, or accepted, whatever. So I will say that did hurt me. And I thought about that one during Erin's talk. I think the other thing for me that's different about this product, and I always, like every talk you hear, it's like, do you have disclosures or something like that? Like I mean, I was just interested in this presentation because this was something I didn't know about, and I don't know if other people know about. I don't even know how we heard about you, Amber, but I guess we had relationships with them, and then like our senior leadership wanted to get this. That's where this came from. And our surgeons were, I think we'd looked at other products. We tried Lumetics. I shouldn't say any names, but we had tried some other things just to try to get our data, because we have a lot of databases, and try to get them all in one place. So this did not drive from down below. This kind of was a top-down initiative. And I mean, I'm very thankful for it. One thing I'm not sure, we spoke to it specifically, but in the initiative thing, so we wanted to work on early extubation. Like you go in and click some buttons and they have all your historical data, and you say when you want to start your project, like it spits out the control data, and then it tells you haven't met because I think I picked like the Biome 95th percentile or something. Like, I don't know that we'll ever reach that, but that's what I picked for the goal. But it will tell you how far you missed it by and how many patients. I think maybe we probably got it this past time, but it's interesting because you kind of get feedback, and they have some kind of way that they measure your ROI and how many bed days, and you can show that to the team, and I think it's encouraging.
Yeah,
I
that's a
will
good.
say what's.
Oh, go ahead, sorry.
Now, I would say what's different about this is the people. I've never really had a product where, like there's like a little question mark at the bottom lower right hand of every single page, every dashboard. I needed reports for a blood meeting, and I could have gotten them out of Excel, out of Armis, out of an Excel spreadsheet, but like they whipped up these fancy dancy things, and I didn't have to do it. Like and I don't know, Amber, if that's like an expectation of what y'all do, but I feel like it is, because you tell me all the time, like, just write us. We can get that for you. And it's really interesting. I don't think we've leveraged our financial data the way that we could yet. I feel like as we kind of get more mature in it, and I feel like that's something that Nancy at UCLA has done. I think I did put the link to the correct article in the chat if you're interested in it. I certainly don't want anybody to feel like we're pushing a product. I just feel like it's a great product. Eddie was interested in hearing about this too. So I think we're just sharing information. There's no pressure or anything like that, but just want people to know about it. Any questions for Amber?
Judy, you bring up a good point too, and I'll wait a second for any questions that might come in, but just being able to kind of automatically, I mean, as you all know, you're tracking, and I'm going to pick on Judy for a second here, but it's like anything that comes up at UVA around STS, it's like Judy will know. So the things that are in Judy's brain, I'm sure there's a list that's about 2 million line items long, but as you mentioned, being able to use that performance manager, and every single time something's updated, it's going to send you an automated update. Your rapid extubation data, you're 10% from your goal. This is what, how many patients are impacted. This is what the ROI would look like that if you hit your goal. Are you getting better? Are you getting worse? It really automates that so that you don't have to keep manual track of every single item. And I do always say that, as Judy mentioned, if there's something that you're looking at or an advanced analysis that you need to do that might take you, 6 hours in your day or 8 hours in your day to do, we want to be the ones to help offload that. So any questions that come up, we love those questions, because one, it helps make our product better to ensure that we can automate it moving forward. And two, we have the tools and the resources to do those things for you. So our job is to make your life easier, save you time, and then again, share kind of across that performance network as well. And thanks for linking the article, Judy, you found it.
I have a question for Amber and Judy. This is Diane Alejo from Johns Hopkins. Thank you for a very informative talk. I was wondering what your refresh rate is on your data. Like, how current is it? So Judy, do you wait until your STS quarterly file is complete and then you upload that to Biome? And then in terms of the other administrative data, how old is that data? And then my second question is, have you worked with any customers importing EMR data and linking that to the financial and registry data?
That's a great question. So I'll answer two things, and I'll let Judy, or Judy, I guess you don't mind me saying that you right now submit quarterly. Is that fair to say?
Submit quarterly, but we just had some things come up that I am going to submit monthly, and maybe by the 10th of the 10th of February, I'll get all of January in to let people kind of get out of the hospital, because people really do look at those reports and you want it as robust as you can. Our financial data will come every quarter, and it comes a little bit after that last of the month because they all have to get coded. Yeah, but it's there. Our end of the year is there now.
Yeah, and
it's January the 20th.
Yeah, and to answer your question, we have some sites that submit to us every single month. So they submit all the clinical data monthly instead of doing a quarterly submit. So we're really actually able to, there's really no limit on when we can take your data. It can be limited, of course, by how up to date the abstraction is, but we have several sites that actually submit to us. Again, they submit monthly, and they're abstracting 2 weeks after the patients are, the procedure date. So what that allows them to do is they actually utilize the data ahead of time. And before they submit to the registry, they're doing things like those risk audits. They have a process in place that says, for any of these events that we're focusing on, prolonged ventilation, reops, I want to get a notification if the data is submitted and I have one of those cases, because they actually go in and they do a manual review ahead of it being submitted to the registry. So it really does just depend on the program. I would say that there are some centers actually that have even their admin data. They close more concurrently, and we can get that, monthly as well. But I would say 99% of hospitals typically close their financial data at the end of the quarter, but that doesn't stop us from refreshing all the clinical data. So we can do that as quickly as the team is abstracting it. And then for your question about EMR data, so that is something that we've started to explore further, because we have a lot of sites that want us to use additional data sources. In the interest of time for this meeting, I won't go into any detail, but we do have a module that's relatively new in the last 6 months. It's called the Biome Cardiovascular Foundational Module. It is actually exists outside of a clinical registry, and it's doing the things that you're kind of asking about, Diane, which are expanding outside of the registry areas and utilizing more of that, those administrative and financial feeds from the EMR to support the analyses. So we absolutely, we do that as well. And then we do have several places that we actually have direct interface with their data mart, and we go in and pull all the data ourselves. So lots of options there, but yeah.
Thank you.
Absolutely. And then, yes, Callie, I'm happy to follow up. I don't know if I have your email, but if you put it in the chat, I can get you at least, again, you already know this because I see it in the chat. There will be differences by institution, but I'm happy to pull kind of a number for you across institutions so I can get you an average for the incremental cost. The one thing that's very interesting there, and I think the question that you ask is really important, is when we think about something, I'll pick on REOP for a minute, but being able to really isolate individual cost of a complication is really important, because we think about like post-op SSI, there could be other complications that come along with post-op SSI, right? Like we would probably hypothesize that patients that have prolonged ventilation are going to be at higher risk for SSI for all the reasons that, of course, we know. What's interesting is with the application, because we have the financial and the clinical data, we can actually isolate the individual incremental cost of a complication. In other words, if we have kind of a pie chart of patients in the data, it's, how many patients had more than one complication and what was the incremental cost of that against patients who had no complications. And then we also have a little bit of slice of that pie that's like, patients that had only post-op SSI and they didn't have any other complication, and showing the incremental cost there. So we are absolutely able to do those, kind of granular analyses, and I can follow up with you on that. I'll get you an average from the database for deep sternal and for superficial. Yes, we do not. That's a good question. Do we abstract data? We do not abstract data. Stuart, anything that I missed from your standpoint that you wanted to add in?
No, I just wanted to emphasize that, all we do is cardiovascular care. So that's why we can maybe we have smart people like Amber, because we focus on that and every day, all day long. And we have long sought to find some way to collaborate with Eddie, and hope and we're talking quite a bit these days. So hopefully when he's down here to see the dentist, we can chat some more. Hope that's still planned, Eddie.
We are on, Stuart. Yeah.
Okay. Good.
Fantastic. Well, I know I really appreciate everyone's time. I see Emily, I see you as well. I won't call you out specifically, but anything that I missed, I know Emily from Maryland, you were on as well. Anything that I missed that you wanted to add or that you had thoughts about based on anything, the conversation or the presentation?
I will be honest, I had to jump off for a few minutes for another meeting, so I did miss most of your presentation, but I'm sure you did a great job, and we are really getting used to using Biome at our site and really into it, so thanks.
Awesome. Thanks, Emily. All right. Well, thank you all for the opportunity. If there's any other questions that come up, again, I know Eddie and Judy both know how to get a hold of us. I have my email there as well. And I will follow up with you, Callie, on the superficial and deep incremental cost for SSI. But I appreciate everyone's time today, and don't hesitate to reach out if you have any other questions.
And thanks, Eddie. Appreciate it.
Thank you, Stuart. Thank you, Amber. Appreciate you.
Take care.
Well, I feel like we need to give people a bio break. Melinda, are you on the call?
Yeah, I'm here.
Would you be okay if we took about 8 minutes to let people just walk around or go make a phone call?
No, that's fine. I mean, I only had one question submitted by your group to me, so I don't really have much of, I don't have much of a presentation, so I think we have plenty of time for that.
Oh, okay, great. So how about if we come back at 2:50, it'll just give everybody a chance to have a bio break or check on whatever they got to check on. And we'll come back at 2:50. Okay, see you in a little bit.
All right, Judy, are we back?
Yeah, we're
Fantastic. Well, hopefully everybody is refreshed here. We have a couple more presentations for our data manager workshop. So up next is Melinda from STS. Melinda's here to field questions and yeah, you all know Melinda, so I don't know if I can give her any introduction that that would suffice here. So Melinda, over to you, and I think you said you had one question you wanted to start with.
I do have one question, and I'll just share my screen. I actually made a few slides just kind of because I read questions all day long, so I need to have it fresh in my mind as to actually what I'm doing, right? Let's see. Okay, can you guys see that?
Yes, ma'am.
Okay, so first of all, thank you for inviting me, and what I've heard so far, I've enjoyed. Had to kind of come and go today around meetings, but it's been nice, Eddie. Thank you and Judy for inviting me. So this is a patient. Actually, this is a question from Loretta. So I saw Loretta on the call. So the patient is undergoing an inpatient workup for CABG after cardiac cath, and it revealed critical multivessel disease. The patient has known chronic kidney disease and is being worked up for a renal transplant, but is not undergoing dialysis at the time of admission. So the CABG was done on 110, On 1-8, the creatinine was 3.89. On 1-9, the creatinine was 4.6. Now, this was drawn in the morning before they did a run of dialysis. However, this is the last documented creatinine before surgery, which is on 110. So they did that dialysis, but they didn't draw another creatinine, which I find a little strange, but they didn't draw one. So when I first looked at this, I thought, okay, so he had one dialysis prior to surgery, but his last creatinine was 4.6. So let's kind of go to the next slide and a little bit more information on this. Oh, I should have my slideshow on. Is this too disrupting not to have my slideshow on? I'm sorry.
I can read it.
Okay, here's the note from the nephrologist on 1-8. So as I've already stated, this guy's got chronic kidney disease, stage 4. It's been fairly progressive, but his creatinine baseline is somewhere between 3.4 and 3.9. The nephrologist says there's no acute dialysis needs. However, his GFR is very low. It's at 18, and he's worried because of the cardioplegia solution and the exposure of potassium during the CABG. So he and the cardiac surgeon talk about what they want to do with this, and they decide that the best thing to do is do one run of dialysis pre-op. And they did that on the 9th. He also documented that we're going to have the dialysis cath in place in case he needs dialysis post-op. So I wanted to first kind of just, because when I looked at this question, sometimes I think people overthink stuff. Like, so my first response when I looked at this is, well, his pre-op creatinine is 4.6, so he's not even in the metric. He's excluded from the metric for renal failure. So in my mind, it doesn't matter if I say he has dialysis pre-op or not. He's still excluded from that metric. So that's kind of how my first response was. So if you look at that metric, so the exclusions for the risk-adjusted renal failure metric, patients with a documented history of renal failure or a baseline serum creatinine greater to or equal to 4. Okay, so this guy has a pre-op creatinine of 4.6. So he's already excluded from the metric. The other exclusion is dialysis. So Loretta's question, and it was a good question. I mean, so do you answer yes to sequence 375? Because although it's an episode of dialysis, it's not something the patient is having routinely. So I was remiss. I probably should have emailed Loretta back and said, hey, Loretta, did they actually do dialysis post-op? Because when I get questions like this, I want to know, did they actually do the dialysis post-op? Because there was a plan documented pre-op that it would be done if it was needed. Okay. So I didn't do that, but I'm sure Loretta's on the call and she'll be able to tell me whether they got it or not. But when you look at this particular case, it doesn't matter if you code it yes to pre-op dialysis or not. It's one run. If they didn't do it post-op, I would say I would code no. It doesn't matter. This patient is still excluded from the renal failure metric because the creatinine is 4.6 going in. And of course, since the baseline creatinine going in was 4.6, then this patient's also excluded from the post-op renal failure. So you wouldn't code it as post-op renal failure either. Does that make sense?
Dialysis affect the risk model, or just was the greater than 4 affected the same? That's the only reason I think it might be important. I know it won't affect the post-op.
It is well, it depends on the risk model you're looking at. I think it's in the cabbage risk model. I don't think it's in all the other ones. So it may affect the risk model. So what I would need to know more information. Did this patient actually get dialysis post-op? And if he did, when did he get it? How long did it run? Because you have to satisfy the need in the training manual that talks about he's currently getting it and it's planned to be continued, right?
Oh, because he didn't get it till 10 days post-op, Loretta said.
Okay, so see that makes it a little more difficult, because it's like, okay, it was 10 days post-op before he even got it. So it really wasn't routinely planned. I probably would have told her not to code dialysis pre-op for this patient, because it was one run. It didn't continue post-op on any routine basis until very late in the post-op course. And, a lot of things could have happened between then. But overall, he wouldn't be in the metric at all, the renal failure metric.
She's worried about the audit. What would the auditors say? They
I
probably
think the
grade you
auditors
anyway.
would. I think the auditors would say the same thing I would. And if they had a question, they would send me a question and say, "How would you code this, Melinda?"
That's what I thought. Because it's
So,
dialysis on a routine. So this is truly end-stage renal disease, which he actually meets the definition for end-stage renal disease by his creatinine. But for dialysis, it has to be, we know you're going to get it like you're not going to make any urine at all. You're not going to clear your potassium. Like you're going to get it. I never knew that. So I'm really glad you clarified that.
well, yeah. So if we look at the dialysis, let me share my screen again. Just go to the training manual. Sometimes it's better
Because it
just
says
to do
undergoing
that.
dialysis on a routine. Yeah.
Okay, let me see if I can figure out how to not share. Oh, here we go. Stop share and share again. I'm getting better at this. Okay.
You're an expert.
No, I don't know. I was doing a webinar on WebEx last week, and I was very challenged with that one. So
WebEx is its own deal.
Pat Hobbs, she was so patient with me, but I was very challenged. So anyway, when you look at this, can everybody see that?
Yeah.
Sequence 375. The definition, now I'm going to tell you about definitions, because a lot of people don't know this because they get questions about it. Definitions are only changed at upgrades. And most often, they're only changed when this sequence retired. Like, so we want to completely redo this renal failure dialysis, and we're going to completely redefine it, right? So if you just read the definition, you kind of miss a lot of what we're actually looking for, because it's the intent clarification where we can add all the information that we really want you to look for, right? Because definition is usually just one sentence, maybe 2 sentences long. And I can't update that. So you'll never see me update a definition in a training manual update, because it can't be done. It's a spec thing that only happens at upgrades. So when you look at the intent, it says includes any form of peritoneal or hemodialysis that the patient is currently receiving routinely prior to surgery with the intent to resume post-op. Okay. So when we think about that scenario, the patient was put on dialysis pre-op, but it wasn't like a patient that comes in and, they're in severe renal failure and you put them on and for sure they're getting it post-op, right? Because sometimes that happens. Sometimes the patient's very sick. They're in severe renal failure. They have to have a run of dialysis and then they have to go to surgery because they're unstable. So, but then they start the dialysis, day after surgery or the next day after that. It's very clear it's going to start again. This was a little different because it was like, oh, let's just optimize the kidneys, right? But there was also some documentation that they would continue it if they needed to. But given the fact that they didn't continue it, they didn't even start it till 10 days post-op, I would have said no to this, because in my mind, that wasn't really an intent to do it 10 days later. Do you know what I mean? Does that make sense?
And I'm glad, Loretta, I'm really glad you asked this. It's complicated because generally it's a little more cut and dry, but this was not cut and dry. So I'm really glad you asked it.
Yeah, and yeah, I get a lot of questions like this. I also get questions like, well, the patient has a fistula in. So can I code that? They haven't started dialysis, but they got the fistula in and it's maturing. No, this field is specific for dialysis, okay? So it doesn't matter if they have a maturing fistula in, doesn't matter if they have stage 4 kidney disease. It matters if they have dialysis. I
expect to resume it post-op like there, but what that's saying is that this patient cannot clear their electrolytes. They're going to have to be dialyzed to clear their electrolytes, and you knew that post-op. So they're either going to go back to HD or start some sort of dialysis post-op, and that's what had to happen.
Yeah,
post-op because their
that's
kidneys
kind
are
of
shot.
the key. Now, if this same patient had dialysis, on post-op day 1, and then continued for several days, I'd have said, yeah, I'd code him with pre-op dialysis, because they clearly had documented a plan to start it if they needed it. And then they had to start it post-op day 1, and he had it for the next 6 days, right? That's an intent. That's a plan to continue. That's why these questions, like this one, are very, very specific, scenario specific. That's why sometimes it's really difficult to share FAQs with people, because I have 2 different kinds of FAQs in my mailbox. I have really scenario specific FAQs. And, I'm reading all kinds of documents. I'm looking at labs and echoes and whatever, depending on what the scenario is. And based on that really specific information, I'm answering that question. That's an FAQ that may or may not apply to somebody else that does not have that exact same scenario. Which is why we don't really put all the FAQs in the training manual, because they don't all apply to everybody. Most of the FAQs I get are very, very specific scenarios. The other type of FAQ I have is the more general, very general type of FAQ that, hey, this is a really good point. We haven't addressed it in the training manual, and it applies to everybody. And those are the FAQs that I update the training manual with. Like, that's why I put, and I don't do FAQs in the training manual anymore. I'll explain that too. I learned that the hard way. So the way we update things now is just either an update, like here, update clarification, whatever. I try not to put FAQs in the training manual. And the reason, you're probably wondering why. I've learned a little something over the last 6 years. So when in version 2.9, there were FAQs all over that training manual prior to me taking that role at the end of version 2.9. And when I had to write the training manual for version 4.2, it was extremely difficult to incorporate all of those really important things that needed to be into the training manual that were written as FAQs. So I decided that I'm going to make this easier on myself, because the next time we have an upgrade, I'm not going to have to decipher all those FAQs and try to figure out how to write them. I'm going to go ahead and write them now. So that's why you see less and less and less FAQs in the adult training manual.
That's so interesting, because now it'll just be a copy and paste for the next. You can add this into the intent clarification.
Yeah, it'll be a lot easier. It'll be a lot easier the next time I have to do an upgrade. it'll be a lot easier than the first time.
That's so interesting.
And, so again, two different kinds of questions that come into the mailbox, the really scenario specific ones. And you might think you have the same scenario and that my FAQ to Loretta applies to you, but there might be something slightly different that makes us answer it a different way. I get a lot of FAQs about things that happen in the OR, and where they take the patient to the cath lab with an open chest, or, and then they close the chest in the cath lab, and what's the actual end of the operating time. And, or then you have a slightly different scenario where they actually close the patient and then they go to the cath lab. So it's different. There's a lot of difference between taking the patient to the cath lab with an open chest, the surgeon going over there and closing the chest in the cath lab, than a patient that you close in the OR and then they go to the cath lab. So anyway, I'm probably belaboring the point, but I just want you guys to understand that that's the reason we don't put a bunch of FAQs in the mailbox. I mean, not in the training manual. And that's also why it's sometimes difficult to share FAQs with other people if the scenario is very, very specific. And the only other thing I'll say, because I get this a lot, well, 3 years ago, you answered this FAQ like this, but now you're answering it like this. And I'm like, well, okay, first of all, a lot changes in 3 years. And intents change, new technologies come out, so that's why we update the training manual. And so it's true, I may have answered something 3 years ago that I'm answering differently now based on updates and changes. So I'm happy to take any other questions. If that's the only question you guys sent me, can stop my share, or I can leave this up in case we have questions that might need the training manual.
Leave it up if you don't mind. One of the and I think GTS might be different than adult cardiac because it's so specific to lung. And I know because Amy talked about this at AQO this year and covered it, but that we actually need, in the training manual, it says a physician must document pneumonia, and our APPs do a lot of documentation. I generally will have an intensivist who's an attending, a physician will also document pneumonia. But could you talk about what we need to document pneumonia in adult cardiac?
Talking about pre-op pneumonia or post-op pneumonia?
Post-op. Well, they're probably both the same, right? Post-op pneumonia.
Pretty much the same. Okay, so we can talk about both, I guess. I don't know what the sequence number for pneumonia is, but it's in here somewhere. I don't look at pre-op pneumonia much, so it's not ingrained in my brain. Do you know by chance?
Yeah, hold on. I got it. I can get it right here.
I think it's like
465, Melinda.
465. That sounds like Callie.
Was that Carol?
Hey, Callie.
Oh, that was Callie.
Okay.
Go Callie, man.
All right. So pre-op pneumonia. Okay, so we used to have, if you remember in the old days, some of y'all have been around long enough to remember that we used to have training manuals that had all kinds of list of criteria and stuff, and you could determine if somebody had a disease process, right? Well, over the years we've decided that that's probably not a really good idea to have data managers trying to diagnose issues, that the providers should be diagnosing issues and it should be documented as such. So again, this is the pre-op. Definitely you want to have a diagnosis that this patient actually has pneumonia, and that diagnosis needs to be from a provider, documented in the medical record. Okay. And the same thing post-op, really. You can't we can't expect data managers of varying different clinical backgrounds. I mean, some people extracting data now have very, very little clinical background, and some have tons. there's a lot of different levels of knowledge out there. And so to make it easier for everybody, most of the stuff that we've updated in this training manual as far as conditions and things, we really want to see that a provider has documented that diagnosis. It kind of lets you off the hook trying to figure out if the patient had sepsis or pneumonia, or I can't remember what version it was, that one that had the definition of sepsis. My God, you make yourself crazy trying to figure it out. So we've tried to simplify that, but the bottom line is, yeah, you need a diagnosis to code these things, and you really shouldn't be using words like possible or maybe or suggested. You really kind of need things that say, yeah, this patient actually has pneumonia. Does that answer your question, Judy?
I'm on mute. Yeah, it was just, I think it might be a little different in the general thoracic, because she was talking about, kind of interpreting the lab data and the fever. So I just wanted to be sure we were all, we're kind of off the hook on having to do that in adult cardiac. And then it does say, it's 6480. It says physician, but that's a surrogate for any provider, right? Any licensed independent practitioner, right? Good. I just got, me, I'm the concrete thinker. And then I wondered, Dr. Salinger did a great talk for us, but he's not able to join us, I think, for questions. And I don't know, this is in sequence 3502, but could you talk about that mitral cleft repair at all? Or do you want to defer that to a surgeon? I feel like I see cleft repair and I take it and I'm never sure. And I've actually asked the question. I've sent it to my surgeon. It's, I'm sorry,
3502. I know where it is. I do this all the time.
Oh, do you?
Well, I answer lots of questions about mitral valve repairs. So I don't have the op note. So I really can't speak to the details, but if the surgeon tells you he's doing a mitral cleft repair, unless you read it and you're like, oh my God, this isn't a cleft repair. What is he really doing here? Right. Then I probably go with it. Or if he calls it a scallop closure, we've even expanded this cleft repair to include a repair of a hole or maybe a little perforation, because we got lots and lots of questions about that, and we really didn't have a place to capture it. And when I took it to the surgeons, they're like, "Oh, just put it under mitral cleft repair." Okay. So, yeah. I mean, unless you have specific questions about that.
No. That was incredibly helpful. That's incredibly helpful to me. The imbrication is, we always see the imbrication word and not the plication. They use that imbrication word, which has got to be the same thing, right? You're just tucking it in.
See, here it is right here.
Just tuck it. I know. You just tucking it in.
Yeah. I try to put different, if I find new words that mean the same thing in op notes, try to add that stuff in, because what one surgeon calls it, another surgeon might not call it. It could be, very different terminology. And then you have other surgeons who, sometimes you just have cultural differences. They might be from a different country that uses different words, right? So you have to just kind of, I think importantly, if you're abstracting the same surgeon's data all the time, it's really important to kind of get to know the words he uses and what they actually mean. And so that you can you feel more comfortable abstracting your cases. I think that's really important. If you have that ability to collaborate with your surgeons and kind of figure out, what they're doing. Like I still abstract TAVR cases, and I've been doing it for like the same hospital for like almost 10 years now. And it's the same guys all the time. So I know exactly what they're doing. At first it was like, oh, I got to figure out what the heck they're doing here, right? But then after a while, you just kind of learn their terminology and you know what's going on. So.
Now, we don't do a ton of these, but could you talk about the difference between a commiserotomy and a commiseroplasty?
Not really.
Okay, good.
Not without I mean,
yeah, no,
I look it up all the
so
time myself because
I look it up too, and I'm like, phew.
And I really don't find I probably need to add some sort of definition there, or best I can. I look for these words, and I also I Google is my friend. I Google a lot of stuff because it's hard to memorize 586 pages of a training manual. Even though I've written it, I'm getting old, Judy, so I have to like check myself on it sometimes, like, okay, I'm gonna look because I think I know this, but do I really know this, right? So it's
hard because they don't come up a lot either. And
they
then
don't.
It's like you think you understand it, and then poof, it goes out my head.
You don't see it very often. And I've even went back in some of the old AQO slides, that when Dr. Badwire, remember when he used to do mitral valve talks all the time? And I still have to go back because I don't see those things done much. It's not like it's a very common procedure. Maybe this would be a good one if I could find a good op note. We could do a case presentation or something like this. Just because it's one that you don't see very often. Callie might be able to speak to it.
Yeah, Callie's going to do the presentation.
So just a general overview. So that when you're doing the commiserotomy, it's actually taking that fused portion apart in the mitral versus the plasty is pulling it back together. So it's, one is taking that commissure and separating something that was fused that shouldn't be fused versus it's come apart and now we need to pull it back together to make it function. Just kind of a
is that the leaflet? Sense. A leaflet. It's a leaflet surgery.
It's the commissure itself.
Yeah, it's the commissures.
I'll find a diagram I can pop into the chat for us.
Yeah, I think, maybe we need to do a talk on that, Callie. Callie was in the OR, so see, her perspective is a little different from mine. So if you can actually see what they're doing, it does make a difference, I think. And even though I did work in an OR, we didn't do open hearts when I was working in the OR at that facility. But so I don't have that like bird's eye view, like Callie does, which I greatly appreciate her wisdom in that.
Screen. Yeah.
Melinda and Judy, we do have a audience member with their hand up. Erica?
Melinda, I have a quick question about sternal wounds. I know it's all of our favorite subjects. Under sequence 6690, the table that's there that is, taken from the NHSN, the link that's below that table takes you to an updated document that was updated in January of 2025. It is relatively similar to what is in the training manual, but there's some wording differences and there's just some general differences. And the reason this came up is because one of my sites was having this disagreement, we'll call it, in what was being documented as deep sternal versus superficial sternal in STS and what the hospital was reporting as deep sternal and superficial sternal. And they kept saying, well, we refer to the National Healthcare Safety Network definitions. And I said, but we go off of those as well. And it opened up a door into to them comparing, what's in our training manual versus what's on there. And again, some of it is just wording. Some of it is hard to compare because of the order of things. And so I'm just wondering if there is a question about something, are we supposed to be following that link, or was that link just there to reference the screenshot above it?
So is this the link, Erica, right here?
Yep.
Okay.
Yep.
So my second question, this patient you're talking about, did they have a re-op during the same surgery? Was there a re-op?
So this actually was multiple patients because we were comparing overall stuff. One of them, yes, did have a re-op during the same visit, which definitely led to confusion for all of us involved.
Yeah. So let me speak to that first.
Yeah.
I'll speak to that one first. So the re-op, we don't handle re-ops like they do.
Okay.
So they attribute infections to re-ops, right? We do not attribute infections to re-op. We attribute infections to the index procedure. So that sometimes you will see that happening because they're telling you, oh no,
that statement right there is very helpful.
Yeah, it wasn't the index procedure, it's this re-op over here. So we are very different from that in that respect. As far as the new guidelines, I probably need to look at them to see if we've missed anything that's essential to be updated. I didn't know they had new guidelines. So,
and again, I don't know if they're new or if it's just like that's when they were last
yeah, probably should
spelling errors and whatnot.
Yeah, I should probably because we updated this, did a lot of updating this before September 2023 because we presented all this at AQO. We had a deep sternal wound session, and so I wanted to go in and make sure everything in there was consistent and said the same thing. And we had some things that definitely needed to be updated. So I can look at that for sure. But I think the biggest thing is the re-op. So if somebody sends me a deep sternal wound question, which I get too many of those, okay? And, the surgeon does not want to tell you if it's a deep surgery. They're not going to be very transparent about that, right? They just say it's an infection. If the patient's not had any re-ops during that episode of care, and I can't figure out based on the documentation, because sometimes it's so vague, you just can't. Then I'll say, hey, what's your infection control practitioner calling this? Because I know it's not a re-op, right? And I know that person has all the information in front of them. They got all the charts, they got all the labs, and I just have little snippets of it. Because I might think it's a deep sternal wound infection, but I don't quite have enough information, or I just don't have all the resources there at my fingertips to see all the information. That's when I'll say, have you collaborated with your your infection people? If the patient's had a re-op, I don't ever say that because I know that infection control practitioner is going to may attribute the deep sternal to a re-op. But even if they attribute it to a re-op, remember in our database, it goes back to the index procedure. So even if they tell you, oh, this patient has a deep sternal wound infection, but it's attributed to this re-op, you still have a deep sternal wound infection and it's attributed to your index procedure. Does that make sense?
Yeah, that's helpful. They just kept telling us your definitions are different. I'm like, I really don't think they are.
That's the biggest difference. And that's where I see the most confusion So even if the patient does have a re-up, like I've had people send me things, and patients have had re-ups, and I'll just like, okay, what did infection control? What are they telling you this is? And they're like, oh, they tell us, yes, it's deep sternal, but it's attributed to the re-up. Well, okay, so yes, they have clearly defined this as a deep sternal wound infection. We do not attribute deep sternals to re-ups. It goes back to the index. So yes, that's a deep sternal wound infection. So
Thanks.
I think it's important to collaborate with your infection people. They're they're the experts. I'm certainly not the expert in deep sternal wound infection. They know all the rules in and outside of it. And I love utilizing them and having people utilize them, but everybody needs to understand that the re-op rules that they have are different than ours. So
Thanks.
you're welcome. Anything else? See any hands or anything? There's a lot of people on here.
Melinda, before we hop off, could you, are there any pointers or any things you want us to know as we send FAQs to you? Anything that's helpful, or, anything you see kind of consistently that, boy, if this didn't happen, this would really help me, because I just want to speak for all of us that we're so appreciative of how quick you get back to us, and your integrity and just everything you do for us to help us, and your patience and kindness. Like, I think I've asked the same thing 50 million times. I can't wrap my head around it. You're still so kind, and we just really appreciate it. Is there anything we can do to help you?
Well, I can throw a few things out. So it's important when you send me a question to try to provide as much information as you can up front, because if you can send an op note, send it, right? Sometimes it won't let you on that first go around. Sometimes other people send it. I don't know how that works, but because quite often a snippet, a little teeny piece of the op note is not really going to tell me much, especially like IMAs. Get lots and lots of IMA questions, tons of them. And most of the time, I want to see that entire op note, because if they didn't use the llama, then I want to see if they use the rima, right? Because a lot of people don't think, when they think about the IMA, they only think about the llama. When we are on calls with the surgeons looking at these IMA questions that I can't figure out, or they're not in the training manual, the concepts aren't in the training manual, then the discussion of the rima always comes up. Well, they didn't use the rima. That's an IMA. So kind of keep that concept in mind. There are 2 IMAs. You can use either one of them. And you should use one of them if you can. The other thing is, don't send me and 15 other people the question. Don't send it to me and then the help desk and then Carol and Nancy, because it just kind of bogs it all down. Because I don't know if the help desk has helped you. I don't know if Nancy's helped you. I'm not sure so I would say just send it to, if you want to just send it to the FAQ mailbox, send it to me, and then I can direct it to whoever it needs to go to if I can't answer it. That would be really helpful, because sometimes I start working on something and then I realize Paul's been working on it for the last hour, and I didn't know he was working on it, right? Let's see. Putting the phone number in is always helpful, because sometimes, especially if you're not a person that sends me lots of questions, because sometimes the email gets mistyped and then I don't have a record, or I can't figure out what your real email is. And sometimes I have to call you. So you don't think I'm just purposely ignoring you. trying to think what else. Oh, this is a big one. And I'm just going to tell you this happens. Please don't send me the same question from the same organization from two different people on two different days. You're going to get the same answer. And I'm going to know that both of y'all sent me the same question. I mean, surely you communicate with each other, right? Your cubicles probably right beside each other. And sometimes I see that as the question is worded slightly different, right? Like, okay. And, that is, well, it's time consuming because I'll read it and I'm like, I thought I just answered that question yesterday. And then I look at the question I just answered yesterday and it's from the same organization, just a different person. And I think, well, either they didn't talk to each other or they didn't like my answer. So that's that's a little time consuming at times.
If I really appreciate you.
Yeah. So anyway, that's probably it. Otherwise, I think
I was able to look at there's 2025 updates for January 2025. There are some slight wording differences, especially for stab wounds. I think it's worth you taking a look at. I don't think it's going to change the overall definition, but there are a little bit of differences that I think you'll like to see.
Yeah, I'll put that on my training manual update. I'll have to
in your
get in there
10
and look
hours
at
a
that.
week, you get to do all this. Yeah. Thank you so much.
Well, thank you so much for having me. I appreciate it.
Thank you.
Is that it, Judy?
Yes, yeah, that's it. We're gonna move along here. Thank you.
All right. Bye-bye.
Yeah, you gotta.
Thank you.
Awesome. Well, thank you again, Melinda. We truly appreciate you and just everything you do for the STS Database Manager community. It's truly awesome. All right. So for our last presentation of the evening or the afternoon here, we are honored to welcome Diane Alejo from Johns Hopkins. She is the Director of CV Informatics. She's also a co-founder of the MCSQI, the Maryland Cardiac Surgery Quality Initiative. Diane has a presentation on how data drives quality at Hopkins. Diane, I will pass it over to you. Feel free to share your screen.
Okay, thank you, Eddie. Can everyone see my slide deck?
Yeah,
we can see it. It's not in presentation mode, but I can read it, which is usually a good sign.
Okay. How about that?
Presentation. Perfect. Thank you.
Okay. So, thank you for inviting me today. I talked to Eddie and Judy about some ideas of what they would like me to share, and really focusing on sort of a foundational data platform that will enable you to improve the quality of your data from an abstraction and documentation perspective, and then leading to quality improvement. So I've given this talk to the STS Data Manager webinar at one point, and this is some slides from that. Because really the approach that I took to share this information is how we build a return on investment by optimizing the STS, adult cardiac surgery registry to improve data quality and outcome metrics. And just to start off with, I know that many of you know Dr. Whitman. He's our surgeon champion at Hopkins. We're really excited to work with him, and he is our surgeon champion. And so if any takeaway message that you get from this information is really identify a surgeon champion at your site, because they can really support all aspects of registry participation. And then I'm also going to share a little bit about advancing the database framework, some things that we've done from EMR data abstraction to support efficiency and accuracy, streamlining data validation and data auditing and prep for harvesting a data file, and tracking, readmissions and longitudinal follow-up using some tools that we built in our EMR. And then I'm going to spend a little bit of time about linking EMR data and STS data to support quality improvement, utilizing quality dashboards for program assessment, where we look at STS data, and our EMR is Epic. So we have some data extracts that we've integrated with STS data. And then really complementing the STS data with EMR data for registry, I'm sorry, for research and quality improvement. We have a large research team at Hopkins, and a lot of data requests come in to get an extract of STS data, but it's just not enough. We need additional data from Epic. So we have a framework to support that. And then regional collaboration, advancing quality to the next level. This is some things that we've done within the MCSQI collaborative, where we linked STS data with administrative financial data to support quality improvement. So that's basically what I'm going to talk about today. I think you all know that there's, a big expense on participating in the STS registry, and how do hospitals want to get a return on their investment? There's STS database participation fees, there's membership fees for surgeons and data managers, there's conference attendance fees. And then if you're going to use the STS data for research, there's a mechanism where you can submit a request for a PUF file. It's called a participant user file. And there are fees for that, and they can range anywhere from $5,000 to $10,000. So while you participate in STS, it gives you a gateway to be able to participate in some of these national research projects using national data. I know we all know about STS vendor fees. We have to purchase software. There's maintenance fees, there's upgrade fees, there's interface fees. If you have a software product that is not a web-based solution, and you retain the software locally at your hospital, there's infrastructure support fees and platform fees and IT management fees. And then it's also, as you know, resource intensive. The salary support of the STS data management team, carving out time from the surgeon champion, the informatics team, the analytic team. If you're going to take some data and you want to analyze it for statistical significance, you need some often statistical support, and then administrative support, as well as the clinical teams such as nursing and advanced practice providers, PAs, perfusion, and anesthesia. And so you put all this money into this, and what do you get out of it? And these are just some areas where we've identified our return on investment. We built a quality portfolio that tracks performance measurement of the hospital and the providers. We track and benchmark processes of care. We develop clinical best practices for quality improvement and patient safety, both at the hospital and health system level. And then we participate in the regional collaboratives like MCSQI, VCSQI, Perfect Care. And MCSQI also participates in the Improved Network, which is a collaborative of regional collaboratives. We do participate in public reporting, and we also use our data as we report to U.S. News and World Report, Leapfrog, Optum, and other managed care organizations who request our STS metrics. We use the clinical risk calculator for assessing risk that the surgeons discuss with patients. We have a regulatory component in the state of Maryland where we have to submit our STS data to the state, in addition to certain reports from our STS analysis report. And that's even to have a cardiac surgery program in Maryland. And then in addition to having a program and meeting volume requirements, every 3 years, there's a certificate of ongoing performance that we have to complete and submit our STS data. We also use STS data for the Joint Commission OPPE metrics. From the financial perspective, the Center of Excellence designation and payer contracting, this kind of falls into the managed care. And like I said, the clinical research framework in terms of doing hospital and multi-institutional research, the regional collaborative research, the STS National PUF, and access and publication, and then also clinical trial participation. And then administratively, we really use our data for operational planning and support, and marketing for, referring physicians. So as I mentioned that, to get quality outcomes, there's a process and you need team engagement. And this is kind of how we do it at Hopkins. We have 2.25 FTE data managers for the adult database. And we do prospective and retrospective data collection. We import data from our EMR into our STS registry software. We have surgeon worksheets. We also have Tableau dashboards that we use for internal quality metrics, reporting out OPPE metrics, and then EMR extracts that generate clinical quality data sets for quality improvement. And we actually slice the dice, the EMR data by the STS risk-adjusted procedure groups. Our physician champion is the director of the VCSQI. And then I have a team of that provide informatics support that actually write the code to do the EMR extracts, to create the Tableau dashboards, and also to upload the data into our registry software. And then we couldn't do this without the regional data manager support within MCSQI in terms of reviewing case definitions and clinical case scenarios. When we send our data to the state, we send it to STS, and we also send it to MCSQI. And a shout out to Eddie Fonner. He will take a look at our data set of all the programs in Maryland, run some QA checks, and give it back to our data managers to do some validation before signing off on data. We look at missing data rates, within our programs in Maryland. In terms of what we do locally, we have a weekly M&M meeting every Thursday. And so the day before the M&M, our STS data management team meets typically on Wednesdays from 11 to 12. We look at our STS dashboards, our EMR dashboards, looking at some of the metrics that we want to look at on a weekly basis and prep for our M&M. And then it's also an opportunity for the data management team to review with Dr. Whitman some of the questions in coding or reviewing operative notes, or if we have an issue with documentation. Dr. Whitman is really the liaison to the surgeons and the anesthesiologists and the clinical providers in order to enhance the compliance and improve the quality of the documentation. We have a plan of action to resolve STS data issues and resolution. Our data managers will follow up with the physician champion and with the surgeons. We do have surgeon worksheets, and the data managers will go back to the surgeons and ask them to complete a worksheet or make any kind of clarifications that are needed for data abstraction. So this is something that Kim Behrens put together for an STS AQO poster. And really, it looks very busy, but it's really a nice summary of the framework that we have to optimize data. And we actually do all of this. And I know it looks like a lot, but once you get the system in place, every time we harvest data, we sort of go through a checklist to make sure the typical, review of the IQVIA platform, but we also look at our metrics and what they're going to be before we submit the data, as opposed to waiting till our report comes back, weeks later. We kind of want to know where we are before we submit data. So we've taken a couple approaches. We have surgeon worksheets. We've optimized Epic documentation by including STS fields in, say, a brief or operative note. We also optimized Epic in terms of extraction, where we go in and we've identified about 75 fields that we validated and know that we could import them into our STS software from Epic. They're still reviewed by the data managers, but it really does reduce data abstraction time of about 15 minutes per STS index record. We also have a systematic review where we meet with the surgeons, review our dashboards. We do weekly submission of reports through the IQVIA platform. Over here in blue is really our data cleanup and reporting process. We have a custom harvest checklist where we go through, we have EPIC reports that we do for validation and adjudication. And then we follow all of the IQVIA checklist reporting that's available within the IQVIA platform in terms of missing variables. We look at the non-analyzed dashboard report, the risk score matches, so typically everything that all data managers do using IQVIA. And then we have some logic that we've sort of, we check on in terms of making sure the data is correct, in terms of making sure, you know, we have an admission status and an operative status. There's some logic for that. And we also check for missing variables, especially the ones that are located, that are a component of the STS risk scores. So there's a lot of referential cross-checking that we do. It's that really helps get our data optimized. This is an example of EMR documentation in the brief op note. We've added some fields that come from the STS data collection tool where we put in here, and we have residents who complete a brief operative note, and it really helps get a little bit more accurate data for the data managers. And this data is imported into the software. Because it's a discrete field, we can very easily abstract discrete data from the EMR and upload it. This is something new that we've just started a little bit, a couple months ago, optimizing, trying to find where the STS predicted risk score is discussed with the patient in the EMR. So Dr. Whitman and the data managers got on a call, and we just sort of figured out how could we do this. And so basically there's a smart phrase that was created in EPIC that basically when they create a progress note on a patient or a clinic note in a pre-op assessment note, they can just type in this smart phrase and it'll bring in this link for accessing the risk calculator. And so they go into the risk calculator and they get the report where you see all the risk percentages as well as the clinical summary. And we ask them to copy that into the progress note. Now, we all realize that when this risk score is calculated, it may be 2 or 3 weeks before the surgery. It may not be as current and as the patient's going into the OR. The data team realizes that. But it is a tool that helps look at some of the risk factors on the patient if they're not easily found in the EMR. We do plan to take this risk score. We actually have an automated system that sends out the next day OR schedule and the next week OR schedule. And we're thinking of actually inserting the risk score when the schedule goes out to the team of the next day OR cases. 9 not advancing. Okay, and so this is what we ask them to do. They go out to the STS risk calculator and they calculate the perioperative outcome with all of the estimated risk scores. And then we want them also to put in the clinical summary. And so what they'll do is they'll copy that into the note. And this really helps. It's just another tool for the data managers to help do some of the pre-op assessments for each case. I don't know why.
Diane, this is Judy. Diane, it's Judy. Do they have to manually do a snippet of that, or how do you get them to get that in their record? Because we're just snipping it in.
Yeah, so you could snip it, but you could also copy and paste it. We actually did this.
Okay.
Dr. Whitman opened up a note, and you can go in and hit copy within the tool. Right here, there's a little thing called copy. And then you can paste it into your EPIC note.
Okay, thank you.
Mm-hmm. One of the things that we've also done is sort of evaluate our extraction process. This is a poster that was presented a couple years ago at an AQO, where we kind of did 2 projects. One is where we did a manual abstraction of data, and then we compared it to an EMR extract to see where the fields matched and didn't match. And then the second phase was we took The EMR extract we imported into our registry, and then the data manager went back and reviewed it, and we looked to see what changed after the data manager review, just to kind of give us an idea of, one, how we can refine our extract, identify where the data sources are that the data managers use to pull the data in from the EMR, and then some of the reasons why the fields would not come in and not match. And some of them were formatting reasons, or some of them were due to different sources within the EMR. But this was just a summary of what we did and how we wanted to validate our process. Basically, our EMR, we extract the data out of Epic, and it goes into by SQL scripts. And then the SQL scripts or SQL code will generate 3 import files. And then this import files are uploaded to our vendor's uploader platform. And then there's an import file processor that processes the file and sends an email confirmation about whether it was successful or not. And then it goes into our software and then and creates a new record. And the data manager will go in and find the patient, find the record, review it, and then complete chart abstraction. This is just a little bit of an example to see why our data didn't match. Sometimes it's case sensitivity. Sometimes there's an extra space. Sometimes the payer codes in Epic may change and we have to translate those codes, or there's multiple payers. Sometimes the labs have special characters in them. And like I said, there could be content mismatches because of multiple sources of data within the EMR. This is just really a summary where we worked with Health Catalyst to kind of show what we did. And we were able to reduce about 12 or 15 minutes of abstraction per record. It enhanced data quality. And I think the most important thing to me is that it really improved our data manager satisfaction. Instead of copying and pasting fields, they're able to spend more time reviewing the chart, and they do check the data that's imported, but there's a lot of high satisfaction. Right now, we only import pre-op and inter-op data just because of the workflow of our abstraction. It's retrospective, but we're looking at adding additional data fields. It's 529 lines of SQL code to generate the data that we import into our STS data software. There's a couple components that you need to do this. You really need some custom fields that you can link the registry data, the registry record, with the EMR record, because you can have multiple operations per an admission. And so we want to make sure we have the appropriate encounters so that we can really match all of the EMR data with the index operation according to the STS rules. I'm not advancing here. This is another tool that we used when a couple of years ago, the STS came out with some minimum thresholds of meeting a 30-day follow-up for inclusion into your analysis report. So we have been doing this for many years for research, where we will take a sort of a cohort of MRN numbers and go out into the EMR and find an encounter that indicates survivability of a patient, like they had a lab result, they had a visit, or they were readmitted and discharged. So we actually did this for all 3 STS databases, the thoracic, congenital, and adult cardiac, when they implemented these thresholds, just to kind of see how many records we could find that indicated the patient survived at 30 days, 60 days, 90 days, 180 days, and 365 days. And this just kind of shows levels of detection of vital status by looking just at encounters, looking at a completed order, looking at labs, or looking at medications. I've talked a lot about EMR extractions for quality dashboards and research. This is sort of a summary of some of the automated Epic extracts that we use. We have a daily OR case log, so that goes out to Epic and finds our cases. We have patient daily weights that are documented in Epic in different clinical areas that we report on in our dashboard. So some of these extracts are done daily, some are done weekly, some are done monthly, and some are done quarterly, and then some are done on an ad hoc demand when we need them. And then our anesthesia colleagues as well, they have a Tableau dashboard really focused on EMR data from Epic that they look at. So there is some overlap in some of the metrics, but again, these are some of the tools that we use to monitor quality. So this is an example of some of our dashboards. We show our volume, open and closed cases, or pump and non-pump cases. And we have an email that goes out every Friday with our volume that you can subscribe to these Tableau dashboards. We look at base deficit, glucose, potassium, and AKI rates. These are all levels on arrival to the ICU. We look at extubation timing. We look at lactate, bleeding. We look at chest tube drainage and temperature. We look at hemoglobin triggers and blood transfusion. We look at a lot of intraoperative fluids. We have some compliance metrics. For example, pre-op testing, MRSA testing. We have readmissions. We look at ICU bounce backs. And then we also include some visualizations of some of our STS metrics. This is the anesthesia dashboard. Again, they look at several things that overlap with us. Transfusions, extubation. They look at pain scores, blood glucose, echo documentation compliance. So how do we do this? So this is just sort of an overview where we take our OR logs, we get all the encounters around the logs, we pull demographics and labs, we go into flow sheets and pull flow sheet data, and then admission, discharge transfer data. So all of this is the EMR transactional system. And all of this really goes to a reporting system in Epic called Clarity. And the Clarity is where we really pull the data. So it goes from the transactional system to our EMR reporting system, which is Clarity, which is this box here. And then we have a cardiac surgery staging database in SQL, where we go from the reporting database to the staging database, where we aggregate all of this data into sort of a case list view. And then data manager will code those cases according to the STS risk adjusted buckets. And then these data feeds are linked to these risk adjusted bucket procedure classifications. And then we generate all of these Tableau dashboards. We also take an STS data extract quarterly and into Excel file from our vendor software. And we've built a readmission dashboard where we slice and dice readmission data. And then we also include in our Tableau dashboard some static reports that we take from the STS national benchmarking reports. You'll see down here the star rating reports. We also pull in some MCSQI metrics so that we can compare our program with the programs in the state of Maryland. We look at OPPE metrics, and then Dr. Whitman, we pull in some data that our VCSQI tracks for checklist compliance. And so this is just a little bit of a bigger viewpoint of some of our dashboards. This is post-op lactate greater than 3. This is the chest tube output. So all of this is Epic data. And so once we define our cohort that these are cardiac surgery patients, we go into our staging database, link that data to the STS patient, because we can slice and dice this by isolated CAD, AVR, MVR. These yellow boxes, we have a sort of a public and a private version, but if you click in any one of these metrics and you have access, you can actually go to the record level and actually see the list of patients that fall into any one of these risk reported metrics. This one is updated. This is updated monthly. This one's updated weekly. It's intraoperative and postoperative fluids. This is our extubation timing, where we look at number of hours of extubation. And this was looked at every week in prep for our M&M. And then this is just a readmission dashboard we created for our quality team. They wanted to slice and dice STS readmissions by a lot of different ways. When people were readmitted, how many days from discharge to readmission, what was the reason, where were they discharged from? So this is really how we use our data. When we set up this automated importing of data into the STS registry software, there are some things to think about, namely when the registry vendor changes their software upgrades, you may not be notified, but you'll find it out when your import fails. Or if STS data definition changes and they're not communicated to the programmer, or there's EMR software upgrades, Epic will change a flow sheet or they'll add a flow sheet. We don't necessarily know about it. We tend to discover that when a visualization changes on the Tableau dashboard, or when we insert one of those fields into the STS software, our data managers will notify the programmer and he'll revise that. There's always EMR documentation workflow, new flow sheets, new revised fields. And then also we need to think about educating the providers about how important the documentation is used as a source for registry participation. Opportunities for success we have found is really optimizing the EMR documentation. Put as many discrete fields that you can in the pre-op H&P. If you're going to electronically abstract it or extract it, or even if you're not, put in smart phrases, things that STS is collecting. It's really good to let your providers who are doing the pre-op H&P incorporate those fields and let them know what that definition is into the notes. The brief op note, I showed you an example of that. And then also in our cardiac surgery discharge worksheet, we have medications listed that the STS requires that we collect, and also the ability to document contraindications. Some challenges that we found in this process is anesthesia documentation and workflow. Sometimes perfusion and anesthesia intraoperative documentation overlap. All of our perfusion and anesthesia documentation is in Epic, but there's different views of perfusion data and anesthesia data. Sometimes flow sheet documentation, we always look around an interval, because the STS requires you to collect data based on a time frame. And sometimes in flow sheet data, the start or the end time may be missing, or with temperature data, sometimes the probe will be removed and we'll notice that the temperature is really out of range. And then blood administration, intra-op and post-op, there's a lot of referential timing for the post-op transfusions. And then one key is how intraoperative massive blood transfusion protocols are in place. That can sometimes change how you're recording your intraoperative blood products, because it's documented in a different area within the EMR from the back-end database table structure. This I put in here. I know we're talking about adult data, but this is something we do for our congenital registry. Our congenital database is not a web-based solution. We actually have a SQL database that sits at Johns Hopkins where we enter data. And one of the things we've been able to do is actually link our Tableau dashboard, connect right to the vendor's SQL tables, and we're able to generate Tableau dashboards right from our STS registry software. And this is just an example of how we do our harvest projections for the congenital database, and how we integrate pulling metrics from a dynamic Tableau dashboard. One of the things that are really important to me is really tracking what we do. And because we do collect a lot of data and a lot of stakeholders want the data, we have a lot of rules and regulations at Johns Hopkins. If it's for research, it has to go through an IRB. There's a data trust. And so my informatics team has a process to go through to check the IRB to make sure if you're asking for STS data, that what you put in your IRB is what you're putting in your data request form. And so we track all of our data requests. I really need to do this because when I need another programmer or we need another data manager, we need to say, we're using this data for these projects. It can take a lot of time to pull data out of the STS for a research project, depending on the scope of it. And that takes a data manager away from abstraction and other reporting. So we actually track all of our data requests. And we have a dashboard that tracks this. My team meets every Monday and reviews all of the new data requests. But looking at STS data, we use it 29% of the time for administrative purposes, 36% of the time for the research, and 35% really for quality projects. This is something that really falls into the congenital side, but I really think this is going to grow on the adult side, is really optimizing the STS registry for research for clinical trials. And there is a stress trial where it was a multi-center trial, but what they did was they leveraged existing resources to improve clinical trials. It was really a novel approach to do this. And so they not only found that they were able to maximize efficiency in data collection by basically conducting your clinical trial, collecting your clinical trial data in REDCap, and then also having the centers export their STS registry data, not all of it, but what is relevant for the trial. And then the trial actually merged the registry data with the clinical trial data that was captured in REDCap, and actually saved quite a bit of money by using a registry data for a clinical trial. So I think we're going to see more of this in the future. Some of the other things that we've done with the research, optimizing STS data and linking it to EMR data. These are two posters we've worked with our Malone engineering colleagues at Johns Hopkins, and we've taken our data and looked using machine learning to look at predictors and causes of ICU readmissions after cardiac surgery. And then we looked at the prediction of heparin-induced thrombocytopenia in cardiac surgery patients. So this was a very wide data set and a very deep data set because we used a lot of EMR data and STS data. And STS data is really nice because it has a really good succinct set of data definitions, and it's validated very well. And so, we built this machine learning framework for these projects. Our machine learning colleagues will write causality papers using machine learning, and then our clinical colleagues will write a poster or a paper and present on some of the predictive outcomes looking at this data. And then I know I've gone over, but I just want to touch base on MCSQI. We're a little bit different in Maryland as a collaborative because we have to send our data to STS. So we partner with the Maryland Healthcare Commission in terms of making recommendations on what is cardiac surgery and how to aggregate data. And what have we done? The return on investment by participating in a regional collaborative, we've been able to, from 2013 to 2021, the impact, we had 78% improvement in early extubation rates, a 34% reduction in prolonged ventilation, 54% in intra-op blood transfusion, 21% in post-op, and then any blood transfusion, a 40% reduction. We just updated this and we sort of listed our tenets. We built some tenets and sort of recommendations or parts of protocols that many of our centers were doing. And we looked at if these tenets made a difference. And we are seeing that getting the regional group together, sharing best practices, sharing what works, what doesn't work, making some recommended things for you to consider putting into your practice, and then the outcome that it had made statewide. This is just an example of our readmission tenets, our blood transfusion tenets. But really, I think one of the other tenets we did was we got the data managers in Maryland, and we did a survey, and we asked some of the things that they do. And then we identified what we felt are tenets or recommendations for the programs in Maryland. Want to have a surgeon champion, have informatics support, have data management quality practices and goals, develop standard operating procedures, validate the different reports, explore data manager opportunities, meet with program leadership, and make sure you fund data managers to go to SDS AQO meetings and carve out time for education among the MCSQI data manager meetings and the national meetings. And then really the impact of this data, what you can do, you can really impact quality, like the extubation and blood transfusion. We did a quality assessment tool in Maryland. We also did an impact on policy by looking at our data to get potentially preventable complications eliminated from penalty, and then our impact on research. And this I'm just going to go through. We in MCSQI, we took our STS registry data, we linked it to our statewide financial data, where we can slice and dice our risk-adjusted cases within the STS by program and by cost, and then cost by major post-op events. We look at average charges by hospital, by the different STS groups. We did a really massive database integration project that was presented by Eddie at the STS meeting last year, where we took 42,000 STS operations, had a 99% match rate with an administrative data set, which is pretty incredible. And then we looked at pre and post index visits, both on the inpatient side and the outpatient side. And that's what this slide shows. Here you have your STS index operation for all of the programs in Maryland. And there were 42,000 patients with a $3.16 billion in charges. And then we did a look back and we got all of their pre-admission financial data, their inpatient and their outpatient visits. And then we did a post cardiac surgeon admission, and we got outpatient visits and inpatient visits and associated charges. And what this lets us see is we can see by inpatient diagnoses where our patients are seeking care and resource utilization. In this case, these are the proportion of diagnosis from in isolated cabs 5 years before surgery or within 1 year after surgery, and then outpatient diagnoses. So we were really able to see the utilization of cardiac surgery patients within the state of Maryland. And then we did a longitudinal view of encounters where we found a patient that would have an MVR at one hospital, have a second surgery reoperation at another hospital. We can do this linking because of the statewide STS, HSCRC administrative data, and we can find a patient who had a reoperation. We know what their charges are, and then we could look at their downstream utilization of different healthcare, ED visits, and radiology visits. And then from a research perspective, we have 22 manuscripts, 19 posters, and 20 presentations within MCSQI in our collaboration using our STS data. And so in sum, that's kind of how we got our return on investment, is by implementing these systems. This was a phased-in approach. It all didn't happen. And a big thank you to Dr. Whitman, Kim Behrens, Darcy Trinko, and Mayuri. These are our data managers. Joe, Carlo, and Scott are on my informatics team. And from MCSQI, a big shout out and thank you to Eddie Fonner, because without him, we could not have this regional collection of data.
Wow.
So Judy, I hope I hit the mark for what you were expecting.
Oh, for sure, that and plus more. But we're over time, so anybody that needs to hop off, please feel free to hop off, and we can stay on with questions for Diane. Do you have a specific form that people have to sign or fill in to get for a data request for research quality, or that other thing in the upper corner?
Yeah, so we have a portal, and there's a link on the portal for data request form, and they fill it out, and then an email goes to them and to my team. My team meets every Monday. We review it. They have to put the IRB number in there if it's for research. We actually have access to all the IRBs, so we check the IRB. Sometimes they have to put a change in research. We check with the faculty member to make sure it's a, you know, there's a surgeon, a cardiac surgeon on the project for cardiac surgery projects. And then we also track our time that we work on the project, just to kind of give an estimation. Because sometimes we will bill, we charge an hourly rate for our programmers who might have to write code to pull data out of Epic. A lot of times people have grants and we ask them to factor in funding for EMR extracts.
Is Dr. Salinger, I think he had to drop off.
I'm still here.
Oh, you're still there. Hi, Dr. Salinger. You're a champion.
Can you guys hear me?
Yes, I can hear you.
Oh, okay, great.
Which means probably everybody can, because I'm deaf, I suppose.
Standing
Diane.
tall, Diane.
Oh,
yeah, that's amazing. It's clearly amazing. Any questions for Diane before and everybody feel free to hop off if you have to, because I know we've gone over. But I definitely have questions for you, Diane, but I got to figure them out in my head. And then I've done too much talking today. Does anybody have specific mitral valve questions for Dr. Salinger before I ask mine?
Sorry I wasn't there live, by the way.
Your video was great.
Oh, good. Yeah, at least I was able to do that.
Yeah, we're so thankful. Let me see people. Okay, I don't
see. So Judy, I have to run for another talk.
Okay, I'll email you.
Okay.
I appreciate it.
Sorry.
Thank you so much.
Thanks, Diane.
Bye-bye.
See you, Diane.
Okay.
Dr. Salinger, I had a question. If primary MR is kind of like aortic stenosis, like, are we all going to get it if we live long enough, or what makes it? Why do people get it?
It's some change. I don't know why certain people get it and others don't, but some people will never get it. Primary MR is, you get this thing called myxomatous changes in the leaflets, and the collagen is actually rearranged, and it's just it's a degeneration of the tissue of the leaflets, and they become bulky and thick. And then because of that, the dynamic forces change, and there's more strain on the chordae, and then the chordae tend to rupture. And there's all different kinds of severity. There's a whole spectrum of how severe those changes can be, with the most severe end being called Barlow's disease.
Oh, that's interesting. And then we don't do these a lot. We don't, because, we have all these words that we have to code. And so we have commiserotomy and a commiseroplasty, right? And so, like, you don't do one for 6 months, and then all of a sudden you see one come through and you're like, okay, is this theotomy or the aplasty, and what the heck are they doing? And what's it for?
That's a good question. I mean, a commiserotomy is classically done for rheumatic mitral stenosis. And
okay. That makes sense.
It's not done that much because we found that a valve replacement is almost always better than trying to repair a rheumatic valve, just because the recurrence rate of stenosis is so high. Mm-hmm. I'm not sure what a commiseroplasty is, actually. It may be more applicable to congenital valves. I'm not sure.
That makes us feel so good. Thank you for saying that. I really appreciate it.
Yeah, probably I should know. I don't use that term.
Okay, it's just in the database, and so we were always wondering. All right, any other questions for Dr. Salinger? I think they were my two. Oh, I think this is a really stupid question, but if someone has mitral stenosis, a replacement is generally the better option, right? Or like, I know in your talk, I think maybe you repaired one, but.
Yeah, no, that's, it's not a stupid question. But most people, and me included, will replace stenotic valves. Certainly in this country, almost always you'll get a replacement.
Okay.
There are some places where they try to repair those valves, but the long-term results are questionable.
And that's the rationale, right? Like you might repair it for a year or so, but 5 years down the road, you're getting replacement anyway. Kind of that same thing with ischemic MR, where we found that, right? Because we used to think repair was always the right idea. And we did get to look at the STS mitral regurg risk model after you. I talked too long on. Yeah, that's interesting. Do you use that at all with intention to treat and what happened and all that on the STS website?
Yes, I use that sometimes.
That's cool. Good to know. All right, any other questions? I know it kept everybody over. Really appreciate you, Dr. Salinger. Thanks for hopping on.
Oh, my pleasure. Thanks for inviting me to be a part of it.
Thank you.
All right. Bye, everyone.
All right, thank you. Eddie, do you want to send us away?
Yeah, I just appreciate everybody's attendance today. Thank you so much to Dr. Salinger for your presentation and coming back and mopping up with the Q&A, and Judy for all you do to help help keep our group together, and everybody for attending today. You guys are amazing and the cornerstone of our database. So truly appreciate you all.
Thank you, Eddie. See you later.
Thanks, everyone. Take care.